Good morning, everybody, and welcome. We are just about to start. It's lovely to have you here today, and isn't the weather nice as well, considering we're expecting lots of bad weather? Thank you. My name is Jenny Walrand. I'm the Head of Communications and Engagement for the ICB. Lovely to see you here. Thank you for coming along. I am your host for today's event, and I'm also part of a wider team of people, so you can see some of my colleagues have blue T-shirts or bright pink T-shirts. They're available to help you with anything that you need today. Before we start, we have the usual housekeeping announcements, so please turn off your phones or put them on silent if you've got them with you. There are toilets downstairs. There is also a lift downstairs to the toilet if you need to use it. The stairs are just back round towards the entrance. There are a number of emergency exits in the room. We're not expecting a planned fire alarm test today. I think there are 4 in this room. Obviously, look for the green sign. There's 1 behind me, 2 over there, and 1 over there. And if there is a fire alarm, please could you gather just across the car park. So on the agenda for today, we are going to be talking about caring where it matters to start with. We're also going to have an overview of our priorities and plans for 2024 and 25. And we're going to hear from some of our guest speakers who are delivering on those priorities. 11:30 is your first refreshment break. There are teas and coffees out there if there's anybody who hasn't had a chance to have them. And after that, we're going to be looking to the future. So having a planning session to shape our priorities and operating plan for 2025 and 26. We'll be stopping for lunch around 1 o'clock. And after that, we will have our annual general meeting. Now, one of the things that our team has been doing over the summer is we've been running a number of wellbeing festivals. There are still 3 that you can go to, and I think there are details about them on the tables. And we've been trying to weave in a number of different things, such as getting checked, eating well, moving more, being kind, and trying new things that support your wellbeing. And as much as possible, we're trying to weave some of those into today as well. So do look out for them. Do enjoy your day. And now it is with great pleasure that I introduce our Chair of NHS Cornwall and ours of Scilly Integrated Care Board, John Govett.
Thank you, Jenny. Thank you. Not quite sure why, whenever I stand up, it proceeded with, there's the exits and able to run away from what I'm about to say. So welcome, everyone. I know I'm in Cornwall. You feel sufficiently far away. You feel like you're in Devon to me at the moment. So I hope you can at least hear me if you can't see me from where you're sitting. But welcome, everyone. So good morning and a very warm welcome to the Royal Cornwall Pavilion Centre today. We're going to be discussing caring where it matters. I'd like to welcome all our guests who have joined us in the room today. And we're actually live streaming, so we've got people watching online as well today. It's a real privilege for me to be here today and joined by so many of you working across our system and in our communities. As Chair of the Integrated Care Board, I wanted to start by explaining why caring matters. When people are sick and feeling vulnerable, they want both kindness and care, and we deliver that in abundance. Doesn't it sound simple? But what we believe and what we want for all our people might not be quite the same at the moment. Sometimes the sheer complexity of our system and the planning it requires can overshadow our focus on local people and what they want from us. So this year we're getting back to what's truly important: our people, our staff, our communities. With the benefit of our integrated care system and a wide system perspective, we know there are many challenges. I'm not going to go through the long list, but just to pick out a few. We all know about ambulance queues. We all know the opportunity that exists in terms of productivity across the whole of the NHS, not just here in Cornwall and the Isles of Scilly. The opportunity that exists is in the acute sector, most specifically, is to look back pre-COVID. As the Integrated Care Board and the Commissioner, we've invested a lot in staff and a lot in around the system. And the trick now as we go forward is to make sure we're utilising all our resources and we're effective, particularly compared to pre-COVID. That's why part of today, tomorrow, and a long-term strategy has to be about aligning where we put our resources, how we put our resources, and how we deploy them. Our traditional structures and pathways often funnel patients from their homes actually into our system and into our acute sector. And to be honest, When I get to that age, I'd rather be treated at home, and I don't think I'm alone in that. So, we're looking to change things as we go forward and focusing more on care where it matters. Now, we've got great colleagues up and down both the county and the region. They've been working innovatively for years on prevention, on ways for caring patients to live nearer where, to be treated nearer where they live. But the real impact needs to be deeper, wider, and faster. In 24-25, this is the year that we're intending to continue our investments in key parts of the system, where we set our priorities and set our programme of work to ensure we focus on people's needs, which is closer to home and really making a difference from them and for us, and being part of our long-term financial plan, and particularly putting in place key changes now that are both a bedrock for this year, but also the bedrock for next year and our future viability. So I can turn to the first slide, please. So these are some of our key priorities. Frailty. I'm going to touch on each of these, if I may. Frailty. Enhancing care in the community for people who are frail, so they avoid urgent admission to hospital, and we give them the best chance of remaining independently at home. Long-term conditions. Stopping preventable diseases from developing and delaying and preventing further progression. End-of-life care, in partnership with Mary Curie and the voluntary sector, offering greater choice to people at the end of life. That is, that's what they want, and they can stay at home and get 24-hour support. Mental health, increasing access to services in response to increased demand, and 24/7 services providing integrated care 24/7 across the whole week, where we can improve treatment. Now, just before I move on from here, we have to move on from what I'm going to call the approach to a lot of these strategies to actually enacting a lot of these strategies. And that's the seminal moment I think we're about to reach. And that will include, as we go forward over the next few weeks and months, looking again at our commissioning intentions to actually say, if this is our strategy, how do our commissioning intentions match our strategy? So everyone will be invited to be part of that discussion, and our Integrated Care Board will start taking some of those thoughts next week in our September board meeting into October, and hopefully concluding as we reach November. Our 3 programmes of work: operational recovery, transforming healthcare, and improving value. Can you move on to the next slide, please? Don't need to read it. I'm going to try and make the points that flow out from that. If we don't deliver on these priorities, we're going to see higher attendance in our hospitals and ED. We're going to add pressure to our hospitals. We're going to drive costs in escalation beds and agency cover. We're going to put more pressure on our staff, reduce productivity and well-being. We're going to have longer waiting for treatment. Higher attendance itself is a negative impact on people's health and well-being. It'll create major cost pressures in today's budgets, next year's, and the medium-term financial plan. And basically, it will stop us investing in all the things that we want to do because we're actually not able to change what we do from today to be able to invest in the things we want to that will actually make a more sustainable solution. So we've got to find a way of moving on from what I'm going to call business as usual, what we're doing now, to new ways of working, and then putting the commissioning intentions and working together as a system to deliver that. If you can move on. Oh, one back. Okay. So on your tables, you'll have a glossy brochure headed Caring Where It Matters. Please do take a look at it. I think it's crucially important that we get some sense. Feel free to read it later, if that's all right. But it lays out, I think, in print what our aspirations are. So, to try and summarise, today we're going on a journey to hear from people delivering our priorities from across our integrated care system. There are, to be fair, some amazing things happening, and we're delivering on that caring where it matters. But we've got to go further, faster, now. So can I invite you to take part in helping us to shape our future together, focus on these key priorities in our interactive session that will follow. We need your expertise, skills, and connections. It is the total system and total collective effort that we make together that will make the difference for our patients and our citizens. Later on today, for those of you who I would encourage to try and attend an AGM, doesn't sound very exciting, does it? But we're going to try and make it entertaining, if nothing else. Do try and come to our AGM, where we're going to share some of the things we achieved in 23-24 as part of the AGM. But I also want to spend some time looking towards the future. And based on this morning and this afternoon, I want to be able to carry our collective view into the boardroom, into our commissioning intentions, and hopefully shifting the dial of outcomes as we go forward. So if I can now hand over to Kate Shields, our ICB Chief Executive. Kate, over to you.
Good morning, everybody. So I've got a script today. I don't normally get a script, so let's see how this goes. So the annual general meeting, I would like it to be more than just part of our governance process for the year. It's a formal accountability meeting, I believe, between us and the people we serve, which is those people across Cornwall and the Isles of Scilly. So John's right, we're trying to make it really relevant, so it isn't just us presenting our accounts and telling you what we've done, but the opportunity for us to continue that dialogue about what we need to do to make things better for everybody that we serve. So I'm delighted to see so many people here today. Some people I know, some people I don't. And this is our second AGM? It is, isn't it? Our second AGM, and an opportunity for us to reflect on the things that we've done together. As Chief Exec of Cornwall and the Isles of Scilly, I get loads of emails from lots of people, and I am humbled by the positive impact our volunteers, unpaid carers, paid workers have on people, keeping them healthy, keeping them well, and helping them to pick themselves up when their lives haven't gone in the way that they wanted them to. It's really easy to focus on what we aren't doing well or getting right, but it's also extraordinary what we are doing and what you're doing to make a positive impact on people's lives across Cornwall and the Isles of Scilly. We're building on our really rich history of collaboration in Cornwall and the Isles of Scilly, and that's something that I think does mark us out from other parts of the country. This has been regionally and nationally recognised, most recently through an NHS Parliamentary Award for the innovative way we work together through the setup and the delivery of the community hubs, the community gateway services, and supporting getting people home from hospital. We also have to remember how quickly those services were set up. So if we give you the ability to move fast and to do the right things, we have people in this room that can make a massive difference very quickly. And that rich community sector, our significant strength, I'd like to just shout out to a few people. So Disability Cornwall, are you here? Yes. Age UK Cornwall, Volunteer Cornwall, Chaos, Pentreth and Humans. You are all amazing because you've been nominated for a parliamentary award, and I really, really hope that you get it. So what's the date of the parliamentary award? Is it 14th of October. So I really hope that our parliamentarians are doing their job to mark you out for the work that you're doing in Cornwall and the Isles of Scilly. So we truly are a team of teams. So Chris Reid talks about that all the time. In isolation, none of us are terribly effective. Together, we're really effective. Our NHS providers, primary care, our local councils, our tremendous community and our voluntary sector, and our people. So we are of the people, aren't we? We are not just those paid and unpaid people. We are from the communities that we serve. There are challenges, and we expect that when we're delivering so many different services to over 600,000 people. But we shouldn't be defined by our challenges. It's right that we should be really focusing on addressing them, but they shouldn't be what defines us and the place that we live. There is one challenge that truly isn't right in this day and age, that there are still inequalities and stark differences in the life expectancy, outcomes and choices for people across Cornwall and the Isles of Scilly. Oh, sorry. It can't be right and it isn't fair that people who live in Newquay will live longer than their counterparts in St Austell. And we could mark out lots of different comparisons across our county where we know people will have less opportunity by dint of where they were born and where they were raised. Things must change, and we all have a role in shaping what 21st century healthcare should look like in Cornwall and the Isles of Scilly. We know we must do more. We're still seeing delays at the front door of our services, those bottlenecks which stop people flowing through to get the care that they need. And the priorities that John's just laid out set the importance for us around what we're doing. We need to have easy access to services 24/7, 24 hours a day, 365 days of the year. And we need to make sure that in all of the really exciting work we're doing, we do focus on those operational recovery programmes that improve value and equity of services. And most importantly, they transform the way that we deliver care to people, Care should be easy to access. It shouldn't be difficult to get through. And for all of us, in terms of how we make our services available, sometimes attitude and culture are as important as ramps and rails. It's not physical access, it's psychological access. So to do that, we need to listen what people want rather than telling them what they're going to get. We need to look at how we move care closer to people's homes so I don't have to travel for something that I really need. And we need to enable people to be able to take responsibility to look after themselves. And that may not always be an exciting prospect for some of the people we're working with. I don't like being responsible, but sometimes I have to do it. And it's a dialogue we need to have with people, isn't it? We've got the infrastructure, we've got the diagnostic and digital capabilities, we've invested in services all over Cornwall and the Isles of Scilly that are attuned to the people that they're there to meet the needs of. And we need to work together to make sure that no one has to go to an institution to receive care that they could receive on their doorstep, at their convenience, in a way they wish to access it. Now, for me, these are really exciting times ahead, and the fact that we have a manifesto from a new government that plays right into this space around us moving care into the communities that support our people. None of this will happen without you in this room, your talent, your creativity, your determination, your doggedness, you're reminding us when we don't get things right and holding us to account. I'm looking at some people as I'm saying that, and holding us to account for when we don't move fast enough. So thank you for joining us on this journey. Thank you for pushing us at parts on this journey. We can't do this without you, and I'm really looking forward to next year and next year's AGM and reflecting on what we've actually done together. Thank you.
Thank you, Kate. And you may have spotted a slide that came through very, very quickly right at the beginning of John's speech with the Wi-Fi code. So if anybody didn't spot it and does need it, it is PAV Centre 2015 with a capital P and a capital C. Yep, there we go. It's up on the screen. Kate's just been talking about one of the projects that we're incredibly proud of that was announced just yesterday, that we'd won a regional NHS Parliamentary Award, and we're now up for a national one, which we're really excited about. But we're now going to talk about another project that, again, we're incredibly proud of, and that is community health and wellbeing workers. And we're joined through the magic of technology, I hope, we're by Professor Matthew Harris. Now, he's joining us live virtually from the Community Health and Wellbeing Workers Conference, and he's been instrumental in bringing them and piloting them here in the UK. And we're also going to be joined by Donna Chapman, if you could come up and join us, she's here in the room, from our Central Integrated Care area, who has also been working very closely with Professor Harris in bringing them to Cornwall. So, Professor Harris, I'm hoping you can hear us. Could you talk to us about how you brought this project here to the UK?
Well, thank you all so much. I hope you can hear me okay. And thank you so much for the invitation to address you this morning. It's been absolutely wonderful, long journey, probably about 25 years or so, for us to bring the Brazilian community health worker role here into the UK. And we've had many bumps in the road, but it's just a wonderful moment for me and the whole, everybody involved in this initiative today, because we, as you mentioned, are holding for the first time our first Community Health and Wellbeing Worker National Conference here at Imperial College, with upwards of 100 community health and wellbeing workers who have come from all over the country, many of whom have come from Cornwall. And it's wonderful to have so many represented here today to participate in this initiative. The reason why I thought back, in 2003, when I returned from Brazil, having worked there as a general practitioner for several years, the reason why I thought we needed to have community health and wellbeing workers like they have there is because, exactly as Kate laid out just a minute ago, we have intractable issues with inequalities. People find it very difficult at times to access care. Sometimes they don't know what's available. Problems arise and they don't know how to necessarily solve them. We need to bring support and care closer to the home. All of the things that Kate laid out are absolutely what the community health and wellbeing workers help to solve. In Brazil, They've been implementing this initiative now for 30 years, and they have over 275,000 community health and wellbeing workers across the whole country, serving 75% of the population. And each and every single one goes door to door, knocking on the doors of their small areas that they're responsible for, and just checking in on people and saying hi and how are you and what's going on and can we help at all, just being helpful. And it's extraordinary how important that role actually is to provide a joined up, integrated health and social care system for residents of any type. This isn't just for people in poor or impoverished areas, this is really for anyone. So in Brazil, they've scaled it initially in very poor regions in the northeast of Brazil, back in the early 1990s, to now be the de facto primary care system, even in relatively well-off neighborhoods in Rio, or Sao Paulo even. And the role is exactly the same. Community health workers, wherever they are, they'll just knock on the doors of their small geographies that they're responsible for and check in on people, working closely with the primary care team in order to help solve the problems that residents have that month. They'll do anything. They'll look at blood pressure, recommend immunizations, deal with the uptake of screening programs, for cancer programs, screening programs, for example. They'll help people stay out of hospital, or they'll send people to hospital when they really need to, when they didn't realize it. They'll identify people who may be suffering from depression but didn't realize, or hypertension or diabetes, and support with taking medicines, making sure that anybody who for example, has suffered from domestic violence or abuse gets support early. All of these things are so important to help resolve and improve the population health outcomes that we all care about, but in a joined up, integrated way, rather than actually vertical initiatives dealing with just specific problems in a transactional manner, which doesn't really help the system or residents as a whole. So it's a really, really exciting initiative. I'm just so excited that now on a day like today, we can hear things, as you've just mentioned, Kate mentioned earlier, the Community Health and Wellbeing Worker Programme up for a national award, jointly with Westminster ICB as well. We're in 23 localities around the country. It couldn't be done without the community health and wellbeing workers, without amazing people like Donna, who's about to speak, and Connie Jungens here in Westminster, who have really forged the initiatives forward. So it's just a wonderful thing to see. And my final point is just to say, for me at least, the main learning that this initiative has provided is that we realise just how much there is to learn from low middle income countries. We very, very rarely pay attention to those settings for inspiration. And if anything, this initiative has taught us not just about how to do the community health and wellbeing worker role here in the UK as well, but how we need to be paying attention much more to contexts such as Brazil, Rwanda, Ethiopia, Malawi, that do more with less. And have been doing so for a lot longer than we have here in the UK, and there's plenty more to learn. So thank you so much for giving me the time to speak, and I'll pass it over to Donna.
Yeah, thank you ever so much, Professor Harris. We do appreciate you taking time out of your conference to talk to us. So let me introduce Donna Chapman, who's going to talk to us about the roles here in Cornwall.
Hi, bring that down. Morning, everybody. So thank you, Matt, for that introduction. And we wanted to bring some of our community health workers here today, but we've got a big posse up in London, so we couldn't really get anyone here today. So I'm going to miss a bit of the story out just for time. So if anybody at any point in the future wants to come and chat to me more about how we've got to where we are, please just come and find me. So this presentation is really going to give an update. So we implemented this in February 23, and we based it on, so I listened to Matt talk about this in 22. I thought, oh my God, I think we can do this in Cornwall. I think it's going to make a real difference for our population, and shared it with some colleagues and got real buy-in. So we said, right, we're going to go for it in our central ICA and test it out. We had some money, we identified our populations of most deprivation, and so learning from Westminster, we implemented it there. We implemented it using the 4 principles of the programme. This is a quick summary of those 4 principles that Matt talked about, and it's comprehensive, so all age groups. It's not limited to age groups at all. It's in small micro areas. It's for everybody who live in those areas, not just specific people or houses, and it's joined up and integrated. And all of those things reflect the model of care in Cornwall that we have. So everything was beautifully linking in together. So this is where we are now. Volunteer Cornwall is our overarching delivery partner who provide operational support across all of our sites. We started in Newquay and Falmouth, Truro and St Austell. Those were our first start when we started just as a central ICA, and we had 10 community workers there. I'm using numbers as head count, not whole-time equivalents here. At the same time, or a little bit later, the teams in the West said, actually, we want to implement this model. So they had some teams in Camborne and Ridgeruth. At this point, I think the board had heard about this and a student video that we'd done and said, actually, we think we want to invest a little bit more in this. So we were able to spread the model. So we've now got 16 in the central area, 22 in the Camborne Ridgeruth area. We've got a team in Bodmin, I think there's about 5 Bodmin that started in July, and we're just recruiting a team in Liskeard, and then later this year we'll be going to Penzance. So these areas are our top output areas based on the council boundaries of index of multiple deprivation. We have 90 areas in Cornwall in the top 10%, and we are hitting half of those, about 40 of those areas with these teams. So that's where we are right now, and these are all the partner organisations. All of these organisations are hosting community health workers, so they're outside of core health and local authority responsibilities. So here's a photo of some of our teams that we've got. We've got 15 in London today, so they were very excited to go there. And just very quick recap, they're allocated about 120 households, and we look in fine detail with our local GP practices and our host organisations where those areas are, and we're led by the data from public health, but we refine it with local intelligence. And they build long-term relationships. So this isn't going to see anything revolutionary overnight. This is going to take time, but it's those relationships that they're building with the people that aren't connecting with anybody or are struggling. And some of the stories are just heartbreaking we're hearing. And it's not referral dependent. So they don't have to access a GP surgery to get a community health worker like social prescribing. The community health workers are in the streets, knocking on the doors in the local community hubs. Their presence is there and they're part of the community. So we're going to play a quick video, a 3-minute video here.
My name is Ellen and I'm a community health and wellbeing worker based in Newquay. The storehouse is right in the centre of the heart of Newquay. It's accessed by hundreds of people a week when we start and add up the groups. We run various sessions, so some of those are closed sessions for certain parts of the community, and then other ones are open sessions that are open to anybody, and that looks different every single day.
This is now 18 months after we first started our community health and wellbeing worker programme. Community health and wellbeing workers are recruited based on their knowledge of communities. They are deployed to build trusted relationships. Not only do they have time to invest in building relationships with people living in the most deprived areas, but they also are not age or condition specific, so it's all ages, it's universal.
And we started in earnest in April. We started dropping off the leaflets and then progressed into door knocking. I have been working, I would say, with about 55 households, so lots of them families or even people on their own. And I know the team are making such an impact on the community that it's making a real difference. We are able to build that trust with the households and them actually giving us the trust to come in and have those conversations and then being able to help them to signpost them or to refer them to organisations where they can get expert help.
As we start supporting people to address some of their issues that are affecting their lives, like finance and housing, and once those issues can be minimised or removed, then our community health workers can start supporting the people they're working with on addressing their own health and wellbeing issues. So we are moving into looking at how the health and wellbeing workers can support things like hypertension case finding and people managing their cardiovascular disease, like diabetes, for example. So this will be a natural evolution of their role over time.
So we're actually offering a really valuable service to people in our community, trying to help, and it's free of charge. You know, we've got access to a database of services, and also you're not on your own. We can be a voice for you, we can help you, we can advocate for you. I said, and at the end of the day, I said, even if I just come and sit with you and we have a jolly good moan about things, I said, that might make you feel better. And
so we've come a long way with this programme so far, and the impact of the work that the CHWs are actually achieving is quite phenomenal. We're able to see that people's wellbeing scores are improving over a period of time. And the main factors that we're finding across the patches, although they vary slightly, are finance, housing, debt obviously, and social isolation and mental health issues. So probably as expected really with the situation for many people in the country at the moment, but you know, our county is no different. Those areas of deprivation where we're actually targeting the service on, actually identifying the most concerns and needs that we're working with people in their homes and in their community with.
Great, so that was filmed in July. We had the first county-wide community of practice for community health workers, and on that day we were joined by the team from Westminster. So we had a team from the Westminster Community Health Wellbeing Worker team that joined as well. So there was a lot of cross-learning going on and building relationships. So here is a summary of the last 18 months. So we've currently got 47 community health workers in 9 areas. That will hit 50 or over 50 by the early next year. They're currently working, this number obviously is dynamic, it's changing all the time. This was from end of July, 497 people. But I need to recognise that it takes time for people to start engaging with community health workers. For example, the data in Westminster show that it's taking about 11 door knocks for one house before that house engages. They've now got it down to 8. So over time, that trust is still building and the message is getting out there. But it does take time, so it's not going to be an instant full caseload for our community health workers. We've done 1,900 visits. So the wellbeing score. So we use MyCore, an outcome tool, measure tool to measure wellbeing. It's a validated evidence-based tool. And the evaluators for the first 200 people over the first 12 months, they couldn't believe the improvement that people were recording of 90%. They've not seen that high in any data set they've had, and they do a lot around social prescribing as well. So we were really, just so pleased with that impact on people. That evaluation was also able to highlight those 4 main issues that were mentioned on the video, that we're finding finance is the biggest thing. So in people's finances, you know, that can be all consuming and you can't sleep. I've even been there in the past. I know what it's like. And some people just can't get out of that rut. So community health workers have been able to help with things like personal health budgets, directing them to the household support grants and debt management services, etc. Also, when the community health worker, the 200 people were asked, what do you find most important about the community health workers? The 2 things that stood out were 38% of people said they just feel supported and understood. And 28% had an improvement in being able to access other services. So those were the 2 headlines from that data. When we distributed the number of people working with a community health worker into our Start Well, Live Well, Age Well numbers, the percentages are on there. And yeah, that's the percentages there. The future plans, we are in the process of recruiting a researcher to sit within the programme with Plymouth University. So hopefully October, that will come online. We're focusing on hypertension and early diagnosis of hypertension, training our community health workers who are more established teams to take blood pressures, working with our GP practice on developing that one. And we're working with Matt Harris and the Westminster team on developing a national maturity matrix for community health workers based on the 4 principles that you saw earlier. So we're helping to develop that. Finally, these are some photos of some joint working we've done with each other. We are working with the NEPC, National Association of Primary Care, who are providing overarching support for spreading the model across the UK. We've been shortlisted for an HSJ award this year, jointly with Westminster, and our West team have been shortlisted by Coastline Housing for a partnership working award as well. So it's all great stuff. There's still lots to learn, and the team, the project team that surround this, weekly we get together and we're problem solving all the time. So we don't know all the answers, but we're getting there together.
Thank you, Donna. And I know there's so much more to say, so do come up to Donna and chat to her in the break. Now, we're going to play a game, a bit of Cornwall Monopoly, and there is the chance for you to win an actual Cornwall Monopoly game. So you're going to travel to 3 different places. Each of those places represents one of our 3 integrated care areas. You'll find out in each of them from guest speakers some of the things that they've been delivering so far this year. So when you came in, you will have had a sticker saying whether you're a top hat, a racing car, a Scotty dog. We always fought for the Scotty dog in my household. And that tells you which player you are. And that will help you decide or know where you're due to go. However, you have also got table hosts who will help guide you through. So if you're on tables 1 to 5, you're part of the racing car group and you're on the Startwell tables. And we would like you to start in the Pencarrow and Trewithen room. If you are on the Live Well tables, you're part of the Scotty Dog group, and you will be starting here in the main room, so you can stay here for the moment. And if you are on the Age Well tables, so that's tables 11 to 16, you are part of the Top Hat group, and you will be starting just upstairs in the Anthony room. There are stairs, there is also a lift if you need to use it. So your hosts are going to support you to find where you're due to be going. If you are watching online, you will get a chance to see each presentation because we'll be swapping between the 3. So I will let you move on to your relevant part of Cornwall.
Yeah, there we go. Right, so I'm not Rob. Rob will be coming in a minute. I'm Tor Buchan. I'm the Digital and Transformation Lead for our Benwick Primary Care Network. And this is...
Rachel Crawley.
Okay, so I will, if Rachel wants to kick off.
Yes, thank you. What a privilege it is to come and speak with you today. I work for NHS England South West and part of the digital transformation project, which is the digital neighbourhoods. Really pleased to be working across Cornwall. We've started with our Benwick as the vanguard of vanguards. But I just wanted to give you an overview of what we're trying to do as a programme. So we really want to use technology and digital to ensure that we're driving a actionable insight using data to help primary and integrated care to meet the needs of their population. And our mission statement aligns so much with what we've heard earlier about to transform the experience for citizens we serve and the workforce so that we can empower integrated working to best meet people's needs in a proactive and preventative way. And we really, as a region, want to work in this way because we need to respond to some of the demographic changes and the challenges that we face here in a place like Cornwall. So I'll hand over to Rob, who will tell you more about the exciting work that they're doing.
So, okay. Good. Right. Hi there. So I've missed the introduction a little bit. So Brave AI, I think Rachel's given us sort of a little oversight about NHS England's introduction, but for Arbenec, AI is a sort of personalised risk assessment tool. So Brave has allowed us to identify cases for preventative care for individuals predicted risk of an unplanned hospital admission in the next year. So an integrated neighbourhood team of healthcare professionals can then use that information to support those in need of wrap care around those individuals. So at Arbenec, we're now doing that. We're successfully using Brave to identify and reach out to cohorts of patients upstream of crisis who will particularly benefit from proactive, preventative, personalised care. We now have a local integrated neighbourhood team of healthcare professionals that are then working with and supporting these patients and developing a personalised care and support plan based on what matters to them. So we now have a systematic, individually tailored process which is identifying people at risk, providing access to the support they need. And the key bit here really is that we are now identifying patients that are at risk of being admitted to ED, and we're able to support those patients and identify them and wrap care around them. Next slide, please. I'm very conscious that this is a sort of a snapshot of what we're doing. I think following this, this presentation, I'd welcome anybody to reach out to myself and Victoria. But the key sort of benefits for Arbenec has been, it's really established a sort of common purpose for our PCN itself. You know, we're beginning to work as a PCN with PCN patients. We have a PCN MDT, and we're really able now to consider about how we use resource for that PCN to be able to support this project and wrap care around our patients, which is fantastic. Quite often when we've recruited and used ours resource, it's been about perceived need rather than about really what we know that we need to do. The other point as well is that it's been a real catalyst for integration for us. You know, we've really sort of tried to develop our integrated neighbourhood teams, and we found, whilst we've been doing that, that when we get in a room and try to discover integration and what it is, quite often people will bring their own organisational barriers to that conversation, and will think about their own systems, their own ways of working, and perhaps lose a little bit of the concept about what integration is. And it's as soon as we got in a room and started to talk about patients and actually doing, that really acted as sort of an anchor for us about that integration. People started to feel quite energised, engaged and quite innovative. So we now have an integrated neighbourhood team in place that involves care coordinators, practice managers, GPs, voluntary sector, public health and virtual teams and community nurses. And we're going to get some fantastic feedback. And one of the things we found, you know, it's still growing. It's very difficult to think about who do we need to have in a room and invite everybody straight away. That we just need to make sure that we keep on growing it one sort of key partner at a time. But one of the things that we found is that as a new person, a new partner comes on board, their outlook and their idea and output will change and give a different reflection on this. You know, we were very, we're looking quite often at patients that potentially could be end of life for the initial work we're doing. Those patients, from a green perspective, are actually at the highest carbon footprint of their lives. Completely different outlook. But some of the feedback that we've had, it was great to meet the team yesterday and attend your MDT and see the use of Brave AI in use. I can see how this will benefit admission avoidance work. I was overwhelmed too by a team's response to the possibility of using technology, such as robots and sensors. Good to see a positive response. The potential of Brave is impressive. It'd be great to chat again soon. There are two areas of work developing across country. Brave could be instrumental in both. The one that is most likely to be of interest is hospital avoidance, especially with winter pressures looming. So you can really see that the integration that is developing and sort of innovation, which is fantastic. And the other thing really is that it's a tool that is firstly identifying patients. For practices, if we didn't have this tool, we'd have staff with their own perceptions and coding, trying to pick out patients for support. And it's a measure for us. For the first time, we can actually measure the benefit of the stuff that we're doing, the work that we're doing, the support that we're doing. And actually, we're beginning to be able to see that now with the work that we're doing, which is fantastic. We're starting now to affect lives and make a difference to the patients, which Tours can tell us a little bit more about how that's happening.
Okay, so our way of working, Brave AI, just to give you an overview of this as well. It's a machine learning tool, but it's not like other tools that we've had before. This is a predictive tool. It will generate a score based on various risk factors to see whether that individual is at risk of hospital admission within the next 12 months. So we are working with Brave. We've had it since June, so it's still fairly new. We've got to grips with it. We're learning how to use it, and we're beginning to see real potential with it. We are working with 3 initial cohorts, about 10 patients from each, just to really start to test what we can do. And then we get in a room with our MDT, but really our MDT is our integrated neighbourhood team. That's what it is. That's what we're moving towards. We've got so many different voices coming in now. It's really encouraging. So our first cohort, this is the highest Brave score, so the most at risk. So you've got a Brave score of 98. Chances are that you're going to be going into hospital. You know, it's really going to be difficult to get that score down. Cohort 2, highest increasing Brave score, so this is over a month. So say in June you're at 45, July you're at 73, something's going on there. What's going on there? And that's when the INT, with that mix of lenses and experiences, comes in, looks at this individual, what can we do? Cohort 3, highest predicted primary care demand. So these are the ones that are going to be coming to primary care 40, 50 times, possibly more, possibly less, sometimes appropriate, sometimes there's unmet need. And again, with an INT, you can really start to pick apart that unmet need. And we're doing this by going back to personalised care and support plans. That what matters to me conversation. So social prescribers, care coordinators, pharmacists, you know, doesn't have to be a social prescriber. Going to those individuals, having those conversations and going, okay, what are we missing? Have you had a med review? Is it that you're coming in for your dressings and it's not healing? Have you been referred to tissue viability? And it's not a blame thing. It's getting all those voices, all that experience, all that encouragement to support our patients. We're now starting to look towards our 4th cohort, which is polypharmacy. So we know with polypharmacy, people who are on a high number of medications, there's all kind of risk factors in there, but also with low attendance. So we instinctively feel that in areas of deprivation and health inequality, there's low attendance, there's low interaction with primary care, and we also then see that pitching up at secondary care's door, late diagnosis, crisis, mental health interventions. So we're really starting to pick apart, and we had a really encouraging conversation with public health colleagues about how we can start to integrate not only people, but data sets. And that's the other part of integration. So I think that's our 10 minutes.
Thank you very much.
Thank you.
Right, apparently this is going to fast forward. Oh, no. Okay, so I'm Ruth Goldstein, I'm from Public Health. I've got 10 minutes. I could talk about this for at least 3 hours. So somebody will have to give me the hairy eyeball as we get going. In Central ICA, I managed to persuade everybody to take an approach around prevention. Really important. I've heard prevention mentioned 3 times so far today, so I'm really happy to hear the word. But actually, it's what do we do about prevention and how do we embed it? So in Central ICA, sorry, can you hear me? Oh, okay. Sorry. So in central ICA, what we started off thinking about, let's write a prevention strategy. Those of you who know me, I'm not a writer, really. I'm a doer. So I did write a strategy. I did what I was asked, and it had sort of 4 elements in it. We need to train up all our staff so that they feel confident to deliver preventative messages. That's really important. Actually quite a challenge because people don't want that training. They're too busy, but we're edging away with different ways of giving people training. Secondly, and I think this is really important for everything we do as an ICB, we have to take our population with us. There's no point us as healthcare professionals or social care professionals having great ideas if our population aren't with us. So the thing I'm going to focus on today is the communications campaign, because that's really important that our population are with us. The other 2 elements, you know, we've got to make the most of the opportunities we've got. We've got to then spread good practice. Those are without a doubt, they're pretty obvious. So I had a lot of mush in my head about what we would do as this campaign. And I talked to lovely Lucy and downloaded all my ideas. And Lucy came up with a fantastic sort of campaign programme. It's going to be a years-long campaign. She doesn't know this, but I want it to be a forever campaign. So she's starting with a year, but really it's going to continue forever. Because we can't expect our population to move from being treated for being ill to actually preventing themselves getting ill in the first place. Because actually the NHS has always been here, hasn't it? So we've always been able to get ill and we've always been picked up. Social care's always been here. We've always needed help and eventually we get picked up. Actually, that's not the way we're going to be able to go in the future. We need people to understand that they need to look after themselves. They need to do things themselves, which can make a difference. So Lucy produced this wonderful thing here, which is kind of our template, which sort of says, out of the campaigns, what are we actually after? And really, our target audience is everybody. It is our whole population. Whether you've just been born or whether you're at the end of your life, you can do something to help you live better at that stage. Making it relevant and making it simple, really important messages that we need. So, as I say, Lucy undid everything that was going on in my head and has been the driving force behind our summer festivals. On your tables, you'll see these. These explain to you what the summer festivals are. They are the start of these campaigns. We've had 5 of them already, and we've got another 3 to come. Is that right? Or we've got an extra one, haven't we? Yeah. So these are, I mean, those of you who go to festivals, whether you're old or young, they've got a good good kind of vibe to them. There's lots of stalls, there's lots of things to do. You can juggle scarves, you can do chair yoga, you can learn to cook, you can move a little bit, you can play football, you can talk to people about your mental health, you can have your blood pressure checked. There's a happy feeling to these festivals. There's something there for everybody in the community, old and young. And they are in places that people go to. So they're in a school, they're in a park, they're in a community hall. I'd quite like to redo these around Christmas, by the way, to replicate the Christmas fairs people go to. This will be a health fair, really important. But the idea is that people start to think about, do you know what, I can do a little bit more for myself. I can move a little bit more. I cannot have that chocolate biscuit this evening. Or I can just take notice of what's going on around and be kind to somebody. Tiny changes that will make a really big difference. So this is how we've kicked it off. Also on your tables, you've got these. These are the guides that go with these summer festivals. But these guides we're flooding everywhere with. They're in libraries, they're in pharmacies, they're in GP surgeries. These have got all of those little tips and things that people need to help them stay healthy. So the whole of the campaign is about everything. Live your life properly. Think about what you can do for yourself. It's never too late. If you're young and fit, you can remain that way forever if you do some simple things. If you're a bit old and decrepit like me, do you know what? You can still live your life well by making some simple changes. It alarms me that we have 99% of our children get vaccinated when they are first born against diseases. 30% of people when they're 70 bother to take up the shingles vaccine, which will also prevent them getting ill. What happens to a person from the moment they're born to when they're 70, which just says, I give up and I'll just take whatever illness you give me? We have to change that feeling. starting. The summer festivals is part of it. The whole prevention campaign in Central is going to be long and deep, and we need the whole of the NHS and social care and our voluntary sector to help us with it. But it is starting, and what I've explained today as a campaign is the very beginning of this movement. Was that within 10 minutes? Perfect.
And it'd be lovely to welcome Bex and Ahmed to the front. Thank you.
Good morning. This is a short presentation that was created by our colleagues here. And just to get through where... Okay. Good morning. Just without further ado, we're just going to play a short clip. It tells the reality of what's the change that's happening at Launceston.
So this is our Health Inequality Hub, which is called Launceston Health Hub, and it's for all the patients and population of the Launceston Tamar Valley PCN, which is Launceston, Callington and Gunners Lake and all the surrounding villages. So we've opened this up led by the PCN and Volunteer Cornwall, but it's incorporating so many organisations now, from adult social care, children's social care, through to so many different charities and CICs, Darrowford Hospital, the local foundation trusts. It really has now become a really large collaboration of multiple organisations, but everybody has got the same aim, and that's around improving health and community here. So we've got lots of different aims and hopes. One that's close to my heart is reducing the appointments of the GP practice, which will mean it's easier for people to get appointments, but also it means that people that are going there that could go somewhere else come here and they get their needs better. So that's our hope with this building, really.
Hello, my name is Darryl Alexander. I will be the low vision advisor for the Launceston Health Hub. And using my experience as a registered blind person, I'll be helping fellow people with sight loss and helping them get the help they need.
My name is Hayley McLeod. I'm an outreach support worker with the Health for Homeless GP practice. The service that we'll be providing here will be a GP clinic, hopefully once a month, for the homeless population within Launceston and the Tamar Valley, to come and engage with a GP and clinicians to support their health needs. This could be a range of medical health needs or mental health needs. We provide a wide range of services and hopefully come and support the people of Launceston and the Tamar Valley.
Our ethos as an organisation is about solving problems, but it's about solving problems through the power of people. It's recognising that all of the problems that we face, whether it's as a community or as a planet with climate change, those solutions have to come from people. Ordinary people like you and me and everybody in the room coming together to form communities of place or of interest to tackle those problems. The partnership behind the Launceston Community Club is the biggest partnership of all, and I think that's something to be proud of in Launceston too.
So so my name is Amit Dhulkotia. This is my colleague Bex McGill. We are grateful to the erstwhile CCG for putting us together. We did a program called King's Fund a few years ago, and we are the outcome of that, collaborations there. So thank you for that. That's one. Secondly, this is a result of trying to be a little bit learning from Einstein, which says doing the same thing again will not give you any different outcome. So this is just another way of trying to really have a go at making a difference in people's lives, and that's really where we come from. Lots of different strategies, but where we started from was really where are people getting their most health met or unmet needs, recognizing that they could be unmet needs. And that's why the focus is on trying to get people their need in where they need it. So there's an existing structure. Most people want to come to their GP practices for their health needs. Well, okay, but they're using it too many times. That means they've got an unmet need, and therefore we might do something different. So this is where it comes from. We have developed from just one single aim to a lot of different avenues or areas where we can help support people. Bex is just going to give us a flavor of who and how we have developed that thinking with that.
I'm not going to talk to the pictures on the screen. You can see the pictures on the screen. I just want to tell you why I'm quirky and why I'm standing here. I'm a psychologist, a clinical psychologist, but this doctor persuaded me to take a GP post. I did it. I'm also a trustee of Volunteer Cornwall, which kind of makes me person first, I guess, and really thinking about VCSE. In this post, in the practice, like a regular doctor, I guess, it gave me a chance to look at what was really driving things for people aside from a biological need. And it gave me a foot in the door to talk with the exec team at Derriford and adult social care and children's social care. So there are 50 brilliant hubs across Cornwall. I'm really proud of them from my Volunteer Cornwall work, but this one also has the hospital working into it and adult social care and children's social care and early help hub with parenting programs. And the next slide shows an array of some of the organisations that are now working in this hub that the GP practice refers to from first point of contact. So you call your GP practice, you book your appointment online, and we pop you straight into the specialist service from first contact, instead of necessarily having a GP appointment at all and having to have a referral or something like that. So we've got drop-in social workers, drop-in social prescribers, and our priority in the practice around mental health, everybody has their appointment within 2 weeks. There's no wait at all. Your appointment might be therapy from first contact. We haven't ended up with a wait list. I don't know why, but we haven't. And this is about operational recovery for the GP practice, as well as starting to work with these organisations around prevention. So we're transforming by moving care closer to home. This is right in our area of poverty, right in the town centre, and we're doing it via collaboration. So we have a patient participation group that's helping us shape this as well. We're very happy to take questions. We are really proud of this work, even though we know it is a little bit quirky, and we're happy to represent these guys that are helping us do it. Thank you very much.
With all of us around the expectations for the health service over the next few years. And I was trying to find it in my book when I spoke, but I found it now. So he talked about mission-based national policy driving mission-based NHS delivery. So 3 presentations that say all of that our focus is hospital to community, analogue to digital, illness to prevention, which each of those presentations has done. And the bit that I really like, he was really clear, the NHS's preventative space is in secondary and tertiary prevention. So we get people, they might be a bit ill when we get them, but we stop them getting really ill. And I just feel really heartened that there isn't much we need to do really, is there, to comply with the new national policy? Because we were doing it before it was written, and we've now got permissions to do more of it. So I just wanted to say that I'm very proud of everybody.
Thanks. I'm Neil Walden. I'm a non-exec on the ICB and an ex-GP. This is brilliant, and this is the kind of model of general practice I'd always wanted to see in Cornwall. But here's a challenge back to you, Kate, from what you just said. This is right for people. It's doing the right thing against the needs of what people need, but it's not being measured. So if you take GP access, we're asked to say what percentage of people's first appointment was with a GP. that's got to change as well. You can change the model, but nationally that's got to be recognised in the way that we are being asked to present data. It's all wrong. It's not reflecting prevention, it's reflecting traditional models of care. So hopefully NHSE will shift that. And can I ask one question for the AI team? Do you think, you used the word appropriate or otherwise against the high group, do you think that AI can help? And this is a really difficult ethical question, because my feeling is that often as teams go around people who are end of life, they're really blind to the reality of what's going on. Does AI inform you that someone's reaching their end of life and they should not be anywhere near an acute hospital?
I'm happy to try to address that, Neil. In where it's been worked and used a lot in Somerset, the teams there, multidisciplinary teams, have found the use of the predicted score to all sorts of cohorts, not just end of life, a really useful tool to start a more meaningful conversation about where people are and what's important to them right now and what their primary goal is, which can then fold around some of the other services that they need. So it's not the Brave AI is a tool, and it's up to those teams within which it is placed to make best use of it. And from what I've seen in Cornwall, each team will take and run with this and do the right thing.
And I think just to go up on that appropriate thing, I think we can't stop everyone from going into hospital. Some people absolutely have to go into hospital, and that's the other thing as well. There is only so much intervention that's morally and ethically okay to pursue. At some point, they are going to have to go in.
Got one last question, then we'll have to move on to the next room, please.
Oh, sorry, Keith Judkins. I'm lay representative to the Penwith Primary Care Network. One quick question, well, it's a comment more than a question, because I think it's something that needs work. But I think it may also be a question that you might wish to answer. How will you in the future engage with those people who would find even that leaflet difficult to read because they can't even relate to the sun? And that's a statistic that's come out several times now in national press. And secondly, how will this relate to those who are unable to engage with any form of computer? And I don't necessarily mean the elderly. There are quite a lot of people across all age groups who don't or won't engage with the internet or with technology.
My name is Lucy, I'm Director of Engagement in Comms. So the booklet that we've got on your table is written as Age Literacy Level 7. It's currently in test mode at the moment with our professionals and our public to double check that they're doing and understanding that content. We are likely to break it down into 5 separate booklets, but there will also be audio and video content, and we'll be using things like TikTok in our new campaign part that launches in September. So we're reaching out as well as sending information to home, so we are meeting and reaching digitally excluded people as well. I'm going to hand us back over because we need to go on. So thank you for our presentators and thank you for coming. All you guests, follow your table host to the Anthony room. Thank you.
I think it looks like we're good to go. I know this doesn't make me any louder in the room, but it does help for those who are watching at home, I'm told. So I think we'll get started. The microphone is the microphone for the room or for home? It's for home, so it'll just be me shouting at you over the top of a microphone so that people at home can. So can the people at the back hear me with my usual voice? I will try and speak louder. Thank you, John. Okay. We've been given a very tight deadline of 8 minutes each and only a few slides, so we're going to rattle through this. Do we want to take questions in between? Because I think that's what it seemed to work well last time. So we're going to do a session around People in Mind, which is a voluntary sector-led integrated commission service for mental health and suicide prevention. Then we're going to talk about, colleagues are going to talk about loss with your dental pilot, and then Juliet's going to finish with the X-ray car. So, thank you, Sam. What is People in Mind? Just for a bit of context, this is a service which is co-commissioned by the Integrated Care Board and our colleagues in public health at the local authority, which is fantastic. We'd love to see more co-commissioned work. It works really well having an input from both commissioners and their insight in this. It's a voluntary sector-led programme which is designed to deliver improving mental health services, particularly around social connection, finance and debt support. There's a whole range of different interventions and support there from a whole range of different voluntary sector providers. Our role is simply to manage the providers in the contract and liaise with the commissioners. It's a 5-year programme. That is revolutionary for the voluntary sector. It gives us certainty for 5 years. It means that we can really look at what's working within the programme, what needs to improve and change, and it gives us time and space to do that. And that's really important when it comes to commissioning the voluntary sector, because it gives financial sustainability and certainty over a long period of time. It's a 16-year plus service, so it's from anyone from 16 years onwards, and you can see we've got partners in there who specifically work with young people all the way up to people at the other end of life. It's underpinned, so there's a whole range of one-to-one support in there that's working on a personalised way of working, starting with what matters to the individual, really digging in, like the community health and wellbeing workers, to what's important to them, what are the issues that they're really struggling with, and working with them with the output of improving their mental health. Underpinning that, we've got a community wellbeing fund and personal health budgets which are available, and I'll say a little bit more about those at the end. And what's great about the 5-year time period is that it really gives us the chance to embed learning. So we're working with a human learning systems approach partner through the whole 5 years of the programme, and that really helps us to understand how's the partnership working, what makes this different from just having 9 organisations working together, and how can we improve services based on what people are telling us. So, in terms of our first 18 months then of delivery, you can already see there's a bit of a gap between the referral numbers and the people that we're working with, and that really just demonstrates the demand that we're seeing out there in mental health services generally. We have a whole range of different things that have been delivered over those first 18 months, but what's really interesting is some of those statistics around income maximisation and debt support. As Donna was saying earlier, that is one of the top reasons why people come to the service, because finance and debt is one of the biggest worries and one of the biggest drivers actually for poor mental health and suicide ideation. But as Juliet was saying in the last session, the bit that's really exciting for us is what do people say about how the service has changed their lives. And we're using the same measurement tool that Donna was talking about earlier, the MyCall tool. We're seeing significant, we've got different ways of describing this, Donna, so I think we need to get our heads together because I like yours better. We're seeing a wellbeing score improvement of 3.4 against a target of 4, so we're over-delivering. People are really feeling that this is improving their well-being, and you can see some of the quotes on the right-hand side there. It is like waving a magic wand. It's about really understanding what's important to that individual and working with them at a pace that suits them to support them to change and improve. And then finally, the 2 elements that we're really excited about in relation to this programme, and again, it's quite an interesting model for future commissioning, is that what we've done in this is we've protected a proportion of the budget each year for additional grant funding for small grassroots organisations. So we've got 9 core partners in the core service, but we've been able in year 1 to fund an additional 17 grassroots organisations. We're talking small amounts of money. It's 185,000, and that's going to deliver to over 1,800 beneficiaries. And there's a real benefit there in being able to get money down to grassroots organisations who are often right at the coalface of delivering for specific people and communities. We actually only budgeted 140,000 for that fund, but because we worked with Cornwall Community Foundation, they had a philanthropist who was interested in contributing a significant amount of grant funding, so we've actually brought in an extra £250,000 worth of grant funding over the life of the programme, and it's a another benefit of working with the voluntary sector. We've got a personal health budget pot that sits alongside that, purchasing a whole range of different things. All of the core partners in our Community Wellbeing Fund, grassroots organisations can access that, and that can be for a whole range of different things. We see people purchasing white goods, furniture, gym memberships, bicycles, all sorts of things that will support them to improve their health and wellbeing. That's everything from me. I don't time myself, but hopefully it was 8 minutes or thereabouts. Any questions before we talk about dentistry?
Emma, can I ask a quick question? John Greer, I'm the Relationship Director of the ICB. So can you just bring back the last slide again? So what I think is interesting for me as a comment is, in terms of what we spend the personal health budget's money on, I'm making a link to the slide downstairs about lack of employment opportunities close to home, and you've got working age population, and how do you have self-esteem and mean your life means something. So I'm really interested to perhaps in the break get under the detail of some of that, because I think there's a connection there.
Absolutely, John, and we do see payment using PHBs for transport. So, you know, there's really, under the legislation, it's very flexible. There's really very few things that you can't use a personal health budget on, and we're really keen to maximise that. We've got a really great range of PHB programmes across the voluntary sector. We're giving out in excess of £1 million a year now in personal health budgets across a whole range of voluntary sector services, and there's a real commitment, as you'll see in the document that we had on our tables downstairs, to increase that over time, which I think is really exciting.
Brilliant.
Dentistry. Thank you.
Hello, hi, I'm Jack. This is Nicola. We come from Lost Revealed Dental Practice. We're doing a new NHS pilot for dentistry, so we're here to talk about that today. I'll just briefly talk through the current system and the problems with it. So essentially, we work under a target system. So the practice agrees a certain amount of targets per year, and the dentist agrees a certain amount of targets a year we're going to commit to, and then you try to hit that target. There's a few issues with that. If we do more than that target, then we don't get paid for anything more. If we don't hit the target, then we don't get paid for not getting to the target. To achieve those targets, we say we see a patient, we get one target known as a UDA. So if we do a checkup, one UDA. And then if we have to do more treatment, we kind of get more UDAs. But it doesn't equate. So say we do 3 fillings, we get a certain amount of UDAs. If we do 30 fillings, we get the same amount of UDAs. So whether it takes 30 minutes or 5 hours, we'll get the same amount of targets. This causes issues with patients with high needs that if they need a lot of treatment, essentially we don't get much for seeing them. So it kind of it puts you off taking new patients that are likely to be more high needs, need a lot more treatment. So it's almost directing care away from the people that need it. Things like when we do lab work, we have to pay the lab to get that made, and sometimes that can cost more than we get paid for even doing it. So we end up paying for people's treatment as well. For the practice as a business, obviously it's really difficult in terms of cash flow, not knowing if you're going to get money taken away from you at the end of the year. So they've got a lot to pay for in a practice, very expensive. So that pushes practices away from doing NHS as well. We were just about managing before COVID, but then with all the things that brought on, a lot of issues, we had a lot of dentists leave us, we had a flood in the practice, all affected us being able to deliver our targets, so it wasn't working for us anymore. A lot of practices finding the same thing, and dentists are, or as we can see from the British Dental Association figures, dentists either want to go fully private or they want to leave dentistry altogether. And this is having a huge impact. You see, last year, 31,000 admissions in hospital for dental-related problems, 50% of which were children. So it's just showing how the failures in primary care now is impacting on secondary care. So this is one of the things we can try and make primary care work. Hopefully everything else will flow. So yeah, I'll pass on to Nicola to talk about the project.
So we started doing the pilot October last year. We've split our existing funding, so there was no new money for this, into 3 parts. 30% of it was to see our existing cohort of patients. So we had to choose our priority groups. We've chosen children, over 80s, and a few medical conditions that we've included. And on that system, we work to the UDA target system. It's working pretty well, but we did have to let some of the patients go, so they've now joined the waiting list. The other two sections, the stabilisation and the waiting list, are sessional fee parts. So we get paid for the session. We see the stabilisation patients, they're referred from 111 or the emergency line. We see them to see and treat their urgent problem, and then if there's other work to do, we can offer for them to come back again to have a course of treatment, and in that we're aiming to take away dental problems that are likely to make them reattend the emergency care again. 50% of them tend to come back. Not everybody does. It might be we're too far away, so they can attend for emergency, but they can't come for sort of a series of appointments. But there are some people who just want to attend for emergency care. The waiting list section is 50% of our time. So we're taking names from the dental waiting list. We're offering them one course of treatment to just get them dentally fit, and then they will remain on the list. The problem there is it's quite admin heavy. It takes a lot of phone calls. The list is probably quite out of date because they've been on the list for so long. These two sections here are the people that actually end up in our surgery. The rest of the time, either they've seen a private dentist recently, they've been lucky enough to get an NHS dentist, or the details are just incorrect, they've moved away, other reasons that they can't come in. So that one's working a bit less well. So we're trying to see whether we can utilise some of that time to see other groups of patients. So we've worked with the community service to see if we can take some of the children on the waiting list there. If we can treat them, then that will take the pressure off of the community service, leaving them to deal with the children who really can't be treated in general practice. But the sessional fee parts, because the financial pressure is not on to try and get the patients through, we can spend the time doing the preventative advice, we can sit down and teach them about the brushing, the diet advice, and things like that, which is going to make the difference. So even though we can't keep them on, hopefully we can get good habits going, helping in the future. Any questions on there? No. Yeah.
We did through Cornwall Council, we did through adult social care and families and children, and they talked about fluoridation.
Yeah.
And that was quite, some people for, some against, but would that be a beneficial thing?
I think
especially that 19% under fives have got decay.
Yeah.
You know, and I think that's what was a really good topic.
Yeah, fluoridation is fantastic. I think water fluoridation would be good, but there's problems with that. A lot of people are against it. There's lots of groups who are trying to get into schools and put the fluoride varnish on teeth in schools. Lots of our patients that we see, they're kind of like, oh, can he have it in school? And it's kind of like,
tablets and drops and things like that.
You can get tablets and drops that you can have at home. We tend to recommend a fluoride toothpaste for everybody, an age-appropriate one, so really little ones you'd want a lower dose than the adult toothpastes. But yeah, fluoride is brilliant, and it would be...
There's a lot of sort of surveys, like went back to like 1956 when there were no dentists in Ireland, and they had to do that.
Yeah.
And there's so much. There was... One of our members is very scientifically involved and was dead against it, but it was a real for and against. So that's gone on our work programme.
It's polarising.
Social care, but we join up. So
yeah,
I'd like to see what the outcome of that is.
Yeah.
All our evidence shows it's completely safe under controlled levels.
It's absolutely safe.
And the benefits are just massive. So it's well worth to go.
So maybe something that will that will cancel a little bit of it as well.
Yeah, be good.
From an admin perspective, is there no way of being able to almost do a data cleanse or data cleanup between your local GP practice and what's on the NHS app? Because obviously you're spending a lot of time on the incorrect details.
It's not from the GPs and it's not from the NHS app. It's a centralised number or email address that the patient's contact to be put on the waiting list. And we're currently working around about 2021, I think, aren't we? But when we started in October, we had people who'd been on there since 2019. So I'm not sure that the people, when they put their name on the waiting list, remember when they're moving house or changing mobile numbers, oh, I need to phone the dental waiting list. It's not on their radar. So we've tried to contact them, but they're just not contactable.
A really good point, though, because is what this is showing us is it's all out of date, it's all a bit rubbish, really. So they talk about how big this waiting list is. It's not a true representation, so actually maybe using something like an NHS app.
Yeah, or the NHS number.
Yeah, would be a lot more useful.
Yeah, that would be good to keep the details up to date.
Sorry, I just feel like I should say, I'm Chief Exec for Healthwatch Cornwall, Debbie Gilbert, and we've been working with our, with the communities, with our residents, with stakeholders, dentists, and we have our published report coming out in October around the dentistry crisis. And I would hope that your slides and your data has been included in that, but I will catch up with you a bit later just to...
We've got lots more as well we can send you. So,
absolutely. So, I just thought I would just put into the forum. Thank you.
Yeah, lovely.
Time for one more.
I was just going to ask really quickly, and it might maybe something we pick up later, but just what the plans are for next steps. So that seems like a really positive pilot, and I just wondered what your aims are just moving forwards for the population of Cornwall and dentists.
Yeah, thank you. Yeah, good question. Yeah, no, there's definitely a lot of positives from it. We're kind of trying to evolve it, as you've heard. Like, we want to try and see what works and gather more data and see what the actual issue is and how we can address it. Definitely, the plan isn't to roll this out to every practice, because you saw how many patients we had to kick off. Not good. We don't want to keep patients on. But we're wondering if just everyone could be a bit more flexible in their contracts they have with the NHS at the moment, and have maybe sessional times that we've got to see these high-need patients, and once they're stable, they maybe move them over into back to the target side, where once they're regular, actually they can get them through those targets. It's just all the patients with the high needs, that's where we struggle with the current system. But yeah, they don't know where to go with it yet, but that's what we're building. Yeah, thank you. Yeah, thanks.
Hi everyone, so I have the immense pleasure to talk about the X-ray car. I am here as probably a poor substitute for the team that actually do this on day to day, which is the lead radiographers and clinicians from RCHT. So I am here to tell you about something that we've been championing in our ICA in the West, but actually it's the team that are the stars of the show. But today they're on the road. They're on the road in the car with the X-ray machine. So please don't ask any really technical questions, because I'm going to have to defer to somebody else. So where did it all start? First of all, X-ray car, no place like home. And I think that really sings to some of the conversations that John and Kate started with today. We all want to be in our own homes as much as possible. So Chrissy, who's here on the picture, Chrissy came and pitched an idea to me. She came and said, what if we could, instead of people coming in for the X-rays, what if we could go out and X-ray people in their own homes so they don't have to move anywhere? And I was like, oh, that's quite exciting. And then we were kind of looking in our integrated care area going, well, actually, that fits with some of our ethos in the West. So we have two overarching aims in our West ICA. One is around health inequalities being our priority. We are a big area of deprivation in our patch. But our second one is, how do we, every day, enable people to stay in their own place and only move out of their place if there's a health or care reason, because we can't do it here right now. So when we were talking about the X-ray car, we were like, oh, hang on a minute, this really, really sings to our overarching aims. And in the West, when we start to look at some of the data, so you'll look and see that here, that when Chrissy looked at it in 2022, there was over 1,000 people who ended up in our acute Intralisk who didn't have a fracture. So when we started to look at it, that's quite a lot of money when you start to add that up. So we were going, OK, let's have a look at the data. Quite a few of those people came from the West. Now, there's reasons for that. One is it's an area of deprivation. Second one is that we have quite a lot of care homes in our patch as well. So we wanted to have a look at that. So as a proof of concept, we were really up for it in the West to go, let's see what we can do. And it was really thinking about, if we could avoid people being conveyed, that means that we would have more ambulances on the road. That means that we wouldn't have people queuing outside our emergency departments. That means we have more ambulances who can then respond to those people who do need an ambulance. We talked about, well, if that meant if people went there, we knew that there was quite a high admission rate. So if you're older with a fracture and you end up in our acute, you're pretty likely actually to be admitted, even if you haven't got a fracture, but you are likely to be admitted. And then what we found is when people were admitted, they had numerous tests. So it wasn't just the fracture. We then ran a number of tests as well. And then people stayed on average 2 to 3 days, which then meant we had some complex discharges to do because people had lost their confidence. So when we were looking at this, it wasn't just the X-ray. We were looking at what does this mean, like looking at that in a whole round. So we went, yes, we're up for that in the West. We'll find some money to support you. So here's some kind of key facts and figures. So we have one car. We started on the 5th of February. It was initially running in the West, but within a month, the system were like, this is really working. Can you go for the whole county? Quite difficult for us, as you can imagine, because the A30's been rather tricky, hasn't it, ladies and gents, in the last few months, but better now. So it's been quite hard for them to expand, but they have. It's run by a brilliant team. So I said it's got a radiographer in the car and a clinical imaging assistant, and they are out. We use the out-of-hours car through Cornwall Health CIC. This is really working in partnership. So we're working with lots and lots of partners. This isn't just one area. This is us all joining together going, so if we could do that bit, could you do that bit? So Cornwall Health, I'm using the term rinsing because apparently we're rinsing an asset. I'm being told that's the new wording you use. So we're rinsing our assets, so we're using our out-of-hours car in hours. Some difficulty sometimes because something happens and we're here. Getting back, it can be tricky. So I have to say our Cornwall Health colleagues are very, very good, and they help us try and go, well, how do we work that? And we do a lot of communication. Also working with our partners in Cornwall Health, we've been able to stop ambulances going, or if our falls car's gone, we've been able to go, it's the X-ray car. So we're kind of really joining up in that system just by being in a room and hearing those conversations. We've been able to really maximise using the X-ray car and making sure they're going out in a targeted way. So out of the 321 people, 283 of those people didn't have a fracture which needed they go to hospital. That's quite a big number. Average age is around 83. We have had 8 people over 101 that they've been out to X-ray. I remember one lady it was her 100th birthday the day after, and she was desperate not to go in. She was going, I don't mind whatever you do me X-ray, I just don't want to go. And she must stay at home and be with her family. Over 50% of the referrals we come are actually from our GP practices. And this is negating an ambulance even being called in the first place. So they're going, we think it's not fractured, but we want to just make sure. So that will be those calls come in. We also get calls from the falls car. Our care homes will phone us as well to say we think, but we're not sure. On average, it's about a 40-60 split. So 40% of those people are living in care homes, 60% of those people are actually living in their own home. And most people are moderately frail when we're looking at that for this age range. And 67% of our images are over hips and legs. So that's where we're kind of more focusing. We do X-ray other things, but that's most of the ones we're going in there. You can see the heat map. We've been all over. We've been all over Cornwall and into Devon. We did a little foray over the border. So the darker the colour, the more we've done. More in the west because that's where we started. But we have covered nearly everywhere. That North Cornwall coast, we haven't really been. This is where the person lives, but very much dependent on where we can get to. We do between 5 and 10 a day, and that is purely to do with the geography of Cornwall, about where we can get to. The team spent a lot of time with people. They really want to make sure that person's comfortable. They build a relationship because actually it's quite intimate, actually, when you're rearranging somebody to get a really good image. And remember, they have one shot. They have one shot at an image. So they've got to get it right. So they do spend a lot of time with that person, making sure they're in the best possible position to get the image right. I'm told, I'm not a radiographer, images are brilliant, as good as, if not better, some of the images that we get if you go into a hospital. They're very good, very clear imaging, and they take a lot of time, as I said, to get them right. And the radiation dose is very low. It's a lot lower than you get if you went into a hospital setting. So I have to say, what's not to love? So, go on to the last slide. So we're going to stop Kath talking, hopefully, because Kath jumps in at this point sometimes. Lovely lady, here she goes. Right, hold on. So, good for the system. I could talk to you about the number of ambulances we've not had to send out. I could talk to you about how that's impacted on ambulance hold at our front doors. I could talk to you about lots of things. But what I really want to talk to you is about what people say. Because that's really important, because this is about people. We can talk about our system, but this is about what difference it's made to our individuals living in our communities. The comments here have taken from, some are from our practitioners, some of them are from the families of the person or carers, and this last comment, which I absolutely love, is it's better than winning the lottery, was from a person who was desperate not to go into hospital again, because she said, it doesn't do me any good. I'm better here. So that was her comment, better than winning the lottery. So I'm going to leave you with listening to Kath.
And when the ladies come with the x-ray, they were absolutely fantastic. Before they'd done anything, they made sure I was all right, asked me if I needed anything, if I wanted a drink or anything. They got me comfortable. They got the x-ray set up, and they were here for quite a while. But everything they'd done with the x-ray, they'd done it so I didn't get hurt or were in too much pain. They were absolutely excellent.
Thank you, Kath. So you might be going, well, what happens if we're leaving people who are vulnerable or at home and maybe had a bit of a scare if you've fallen over? I know what I feel like when I fall over. I feel a bit wobbly afterwards, a bit like, wake up. So what we will do is we don't just go and leave people alone. So we do a follow-on. So we'll be contacting our community services to say, could someone pop in? Might be a voluntary sector partner. We go, could you just pop in or give someone a call to make sure they're all right? We leave them numbers so they know who to contact if they haven't got anybody around them. So there is that kind of follow-up loop. We've got more to do. I think we could do some really good work around how do we then follow up. If you've been to see the Brave AI, how could we do that personalised care and support planning with those individuals? And so we've got a bit of work yet to do. But thank you. That's the X-ray car. I'm happy to take any good questions. No technical ones. Good. Thank you. Thank you for your time. Thank you.
Brilliant. Right, we're going to rattle through this at a proper canter, OK? We were fast up to now. We've got to turbocharge it now, OK?
Keep the door open because it's really hot. If people can't hear, I can shut it.
Yeah, that's fine. Brilliant. Thanks, Jenny. OK, right, we're going to go through this really, really quickly. My name's Amanda. I'm lovely to see everybody here. I know some faces. I work with Volunteer Cornwall on climate resilience, which is really, as far as the NHS is concerned, the connection between human health and planetary health. And it's absolutely about de-siloing everything. If we get it right in relation to planetary health, we're going to be getting it right in terms of human health and vice versa. And we get it wrong on one of those, we sort of knacker the other half of it as well. I'm online. Probably need to not swear a lot. OK, right. So I'm going to talk very quickly about one of the networks we're running, which is essentially about understanding the value of green spaces for health. This is us, and this network we've just referred to as a string of green pearls, which is also happens to be a plant. Who knew? So essentially, we know what the problem is. The problem really is that we've got loads of sick people, we've got a pretty sick planet, actually, and we've got sick purse strings, actually, in terms of not enough money. So we know that in terms of the social determinants of sickness, only 20% of input is really from the healthcare system. The rest of it is everything else. We tend to forget that when we're inside the system, but it's a really important thing to remember. We've got lots of staff working really, really hard who are suffering because they have got an increasing number of people in the world, and so we've cut off all those connections. They're crucial to us being well, which is what a lot of the emerging science is saying. So we have lost more wildlife and and we were one of the least best, one of the worst nature-connected communities in research at the moment, which is just staggering considering how we perceive ourselves as a country. So we know what the evidence is saying. We know that the evidence is saying that the natural world outside, because we've disconnected it from ourselves, is actually really good for us generally, and in terms of health and social prescribing, that's coming through. We know that in actual fact access to the natural environment is really important in terms of staying well and getting better faster. We've got researchers in Cornwall at the University of Exeter, ESI, ECHH, internationally understood organisations all saying this to us, and we also know that if you have got access to green space, it will improve your levels of high well-being, even if it's just taking a small walk wherever you are. People who are involved in it can start to see impacts on their health and well-being, and of course we know that the same applies to patients. So if we combine patients and staff and access to green space, then suddenly we start to go in the opposite direction from the way it can feel sometimes, where everything is getting bigger apart from our budget. Stress and workload and system demand and complexity are all getting bigger, but the amount of money we've got to spend is getting smaller. This might be one of our key secret weapons in actual fact that's also delivering against our nature and climate and ecological targets as well. So this is where you start to see it's all the same stuff. Descartes split it all up in the Enlightenment. I've got such a beef with Descartes. It's not at all that disconnected. It's all the same. So what if we used our estates as a fundamental part of health creation? Health creation I refer to as the more ambitious, bigger sister of prevention. What if we started to do that? Because suddenly you start to see lots and lots of boxes being ticked. So we are just rolling our sleeves up in our work, funded by the ICB, to work initially through primary care, but then across the system. And we're starting with tiny pots of money from the fantastic public health team who completely get this. We've started to build tiny spaces actually on site at practices or in adjacent community organisations with money that's about £1,000 or £1,200 that you give to staff who want to create human and planetary health connections. And suddenly they're coming up with all of these amazing ideas and saying this is, they love it. Their patients love it, practice managers love it because they feel as if they're giving something back to really, really hard-working staff. This isn't just in the West, this is all the way across the ICS. Everybody is saying they can really see the benefit of this. Tiny pots of money, exponential and disproportionate benefits. And of course, all of this is contributing to our climate and nature targets as well. But in actual fact, it's understanding that this is about people and their connection to place. Mayors love it. If mayors love it, then people love it, and staff love it, and patients love it. And also, we're now nominated for a national award because of this one at Pentor, where suddenly people really got behind a really positive thing. We get lots of clinicians saying this is the best part of my job, because it feels like I'm doing something really positive about a big amorphous scary thing outside. It's also benefiting staff, it's also benefiting patients, and it means that suddenly you can have meetings outside for either consultations with social prescribers or just staff taking a break or having work meetings. It does everything for everything. It's a very simple linchpin of health and well-being in actual fact, and when we know and also practice to see the benefit and can have an opportunity to look ahead rather than constantly dealing with the horror of today and what fresh hell every morning can bring. They're starting to be able to plan ahead. So I would say, in terms of primary care, we've got 17 green pearls and counting. And we've got a map of all the places where we're doing fantastic stuff on food and fantastic stuff on green spaces. Loads and loads of people doing brilliant stuff. We know that in actual fact, the survey respondents to our general awareness survey are saying it's really important their employers are taking this seriously. Again, it goes back to staff wellbeing and recruitment and retention. We're working with RCHT with a little bit of money for a green spaces ranger this year. We really want to try and find money to continue that. That's the map of RCHT. It's basically a bunch of buildings about sickness. This is not where you want to be thinking about health creation, unfortunately. So we're nicking ideas, repurposing from Southmead, who've developed this fantastic walking and green space map so that staff can actually get out and about, and patients and visitors. We've redrawn the map of Trelisk, literally with a green felt pen. There's loads of green space, but it wasn't on the map. And intellectually and psychologically, it's not on the map. The gardener said, my job is not included on this map, because you can't see any of the green space. Now, they do an incredible job. So simply by doing that, she felt as if her job to get to it. They don't know where the green spaces are, for God's sake. There's loads of them everywhere, but they're so busy. But they know that it's beneficial for them and their patients. So now we're doing all of this stuff with our Green Spaces Ranger, who's doing amazing stuff. CPFT have done incredible things with the lottery-funded project called Healing by Nature. I'm wanting to make sure they've got a 4-acre site at Trevillis where they can really, really optimise what they've got for staff and patients. And I would say I'd finish with a comment from Anthony, who was involved in the Roseland community site, amazing permaculture site, where suddenly you've got loads of people. A patient is flipped into a contributor to health and well-being in their local community, which is much more than a blister pack can ever do. And he said, I was sort of not coping 100% during this COVID thing. That always causes me so much heart pain to think that that meant he was having a really shit time, actually. But now I feel as if I've got something I can contribute to. It's making me feel as if something really, really positive, something I can actually take part in and involved in and participate in, and I'm starting to feel part of a team. I think people need a way to contribute and find a way to take part and be a productive human being and be actually part of life. And for me, a simple ask. And for me, the garden is just a starting point for me to realise my potential, and that's from Anthony. So if you want to know more, you can have a little look at our website and drop me an email. But this is just, it's not rocket science. There's lots and lots of common sense, and loads of people want to get involved. Thank you. Over to the next one. I think we're going to go straight to Chris, I think, so that we can catch up on ourselves.
If you've got any questions, do please ask them over lunch. We've got 5 minutes each now.
Yeah, hi, Chris Reed, Chief Medical Officer, NHS Cornwall, Scilly, ICB. I'm going to talk about diabetes. I'm basically going to say what's the problem, what do we want to achieve, and how we're going to do it. Okay, what's the problem? One metric to remember if you're going to remember anything. Right now, the people with pre-diabetes, 28,000. If we carry on the way we're managing our diabetic patients, it's going to swell to 84,000 within 5 years. We've got about 33,000 already who've got diabetes, and that'll swell to about 48,000 if we do nothing about it. We can't. It's not the right thing. I was going to dare us. I was nearly going to say we can't afford it. We can't afford it for the patient's perspective because it's going to cause complications. So I'm going to talk. I'm going to give you a demonstration. So Jess has been doing an amazing job being the hospital at that end, and Janine's going to be the community and primary care voluntary sector. Because over here, the hospital, it's full of amazing people and amazing specialists, but it's where complications happen. It's where expensive drugs get used, and we want to avoid people going there. So we want to be over here, and there's a conveyor belt. There's a conveyor belt with pre-diabetes, so that's the bit you get before you become diabetic. And to be fair, I'm not going to talk about type 1 because, to be fair, they're the people where it switches off overnight, and we do then need to provide a personalised support of management with the right technology and medications. So this is really about type 2. So I think, this is my GP coming at me, there's a conveyor belt that we're all on. And if we do think, we often end up pre-diabetes, and if we still do nothing, we'll end up with diabetes and the complications. That conveyor belt moves differently, your genetic variants, but really the issue is some people are sprinting on top of that conveyor belt, so they're literally sprinting towards it because they haven't got the education, what's called the health literacy. They don't understand what they should eat, or they can't access what they can eat. Moving green spaces is what Amanda talked about. So if we can give people the right education so they know how they should behave, how they should eat, move, sleep, socially interact, you can actually reverse pre-diabetes. So we want to see our target, what we want to achieve in 5 years' time, is we want to have the diagnosis, the incident of us diagnosing diabetes to go down. We want pre-diabetes to go down from 4,000 to 2,000. We need to be bold to do that because we're not going to turn the tide if we don't. And we want to reduce the complications because there will still be people with the greatest will in the world who will have the complications. Complications are terrible in diabetes. You can go blind, you can have a heart attack, you can have a stroke, your kidneys can pack in, you can lose a leg. These are horrible complications. They cost an inordinate amount of time, resource in the secondary care sector, and therefore what we want to do, our diabetic strategy, is about moving that resource, which is weighted too much over here, to much more over here. So if you think of the triangle, there'll be much more of the resource sitting over here. We'll still have a little bit of resource over there, but we want to bring the specialists out into the community. So within our year one, we want to have the voluntary sector commissioned to do that structured education, to really go and target the populations that need it the most, because there's a health equity issue on this as well.
And it's for all the
we want to roll out
patients
those
and population
multidisciplinary
of the
teams.
Launceston, Tamar
We want to
Valley.
roll out super clinics. And as I said, we will build on that over the years, so that by year 5, I would like to be able to see that we've achieved that reversal, we've turned the tide.
So many
I just want to, when people say, yeah, but how are you going to do it? Is it possible? Absolutely, it's possible, because everything that's in the plan is happening in some shape or form already. It's not rocket science. We just need to do it well and better and have consistency. And I'm going to now become a real.
Everybody has got the same aim, and that's around improving health and community here.
At the weekend,
so we've got lots of different aims and hopes. One that's close to my heart is reducing the appointments of the GP practice, which will
so these are people who've got
mean it's easier for people to get appointments, but also it means that people that are going there that could go somewhere else come here and they get their needs better. So that's our hope with this building, really.
Hello, my name is Darryl Alexander. I will be the low vision advisor for the Launceston Health Hub. And using my experience as a registered blind person, I'll be helping fellow people with sight loss and helping them get the help they need.
My name is Hayley McLeod. I'm an outreach support worker with the Health for Homeless GP practice. The service that we'll be providing here will be a GP clinic, hopefully once a month, for the homeless population within Launceston and the Tamar Valley. Engage with a GP and clinicians to support their health needs. This could be a range of medical health needs or mental health needs. We provide a wide range of services.
And work for Partnership Trust
and support the people of
community assessment and treatment options. I'm going to do a super fast counter through. I'm going to use some acronyms. Give me a shout if I am. I talk really fast anyway, and I talk a lot, so being confined into a few minutes is quite tricky. Sorry, can I have the other slide first? Because it's sort of easier.
Whether it's as a community or as a planet,
so,
climate change.
Why do you need to go to an acute hospital? What's there? Why are we sending everybody to an acute hospital? Do you need to go to that hospital? Because actually that's the most important thing. These things here, you absolutely need to go to an acute hospital. If you are having a stroke, if you are having a heart attack, if you've got sepsis, if you are in real huge amounts of distress, you need to go to your emergency department. And when you get there, you need to get in the doors of that department and have an amazingly qualified specialist team leap on you immediately, because we know that will improve your life, your cognition, your brain and your limbs, and that's super, super important. However, if you speak to the paramedics and you say, in your day, are you blue lighting everybody in? And I thought it was about 40%, 50% of blue lights. They're tiny, and they were like, no, it's about 40%. So why are we taking it else then? What we're telling them, because people are stressed and upset, something different happens, something's not right. Actually, can we sort it out somewhere else? And it turns out probably we can. So what you need is someone to come and see you in your house to do a face-to-face assessment. They need to check your observations. They need to have a chat with you to find out what's going on. They need to do some basic level tests. And sometimes, actually, that very first point of call, a lot of people will be very happy and reassured. They've fallen on the floor, they've been picked up, they're fine, it looks like they haven't broken anybody. You've got some really enhanced specialist paramedics that say, do you know what, crack on, you're absolutely fine. In a week or two, go and see your GP because your blood pressure's a bit high, see how you go. They might get there and go, do you know what, you've had a fall. Don't think you've got a fracture, but actually you might have. But don't worry, you don't need to go anywhere. We've got an X-ray car that can come and take an X-ray. Don't need to leave your home. Still really comfy because you've still had a bit of a shock. You've had a bit of a bad day. But actually you've got a whole load of people that have come to your house. Didn't need to go to the emergency room. Didn't need to go anywhere. That's all grand. On your set, no petrol, no people running around and going to different places. But actually someone gets there and you're like, I can't stay here. It's all really worrying. This is the end of the straw. It's the straw that's broke this camel's back. We've been trying to get help for ages and we just haven't got it. So actually, do you need to go to an acute hospital for that? Well, you sort of did in the past. There was nowhere else to go, really. But now what we've got is some community spaces that we can go to instead. So what we can do is we can have a chat and do that first intervention, and we can say, well, actually, you can stay at home, so that's all grand, but actually some of you can't stay at home because actually you don't look very well, and we want to see what's happening. But also, you don't need to go to hospital for that anymore, because we can do your blood tests and we can get the results right the way. We've also got these really clever CT scanners and MRI scanners now. So actually, all those investigations that you were going to go to the acute trust for, we can do here. So we can ask you to go to Bodmin or to West Cornwall, and we can see you, and we can say, do you know what, actually, I'm a bit worried. You did hit your head and you're on these blood thinners, because everyone's on them now. And actually, there's a really tiny chance that you've had a bleed in your brain, and we sort of really need to check that out. But we can just get it checked. We can send them across the corridor and they can have their scan. We can speak to the specialist at the hospital and say, Mrs. So-and-so has had this, but actually her scan's looking really good, her blood's looking really good. Family is still a bit stressed. We're still a bit worried about her blood pressure. It's still not quite right. So we'll send you home, but we'll keep an eye on you on our virtual ward. And what that virtual ward will do is we'll ring you 2 or 3 times a day. We'll give you some super kit to take home with you. And we'll be able to say to you, how are you doing today? You know, can you do your bloods for us? Well, actually, blood pressure's looking much better now you're at home, in your own environment, in your own front lounge. Maybe we don't need to rush in with lots of medication to treat your blood pressure, because it's looking really good. How's the headache going? Is it any worse? Is it any better? Let's look at your medicines, etc., etc. So you're at home now. You're getting much better, much more quickly. You're not at risk of infections that you might be in hospital. You're not at risk of falling over because you don't know what the way to the loo at 2 o'clock in the morning. And actually, you're much happier at home. And actually, you're getting up to make your own cup of tea, and you're getting up to make your own dinner. And that means you're going to be able to do that for a bit longer. So that's all brilliant. Now, we might do that diagnostic centre. We might, do you know what, there's a tiny little bleed on your brain. There is. But actually, we've spoken to our colleagues at Derriford, and they've said we wouldn't operate, but actually you do need to keep a bit of a closer eye. We do actually need a nurse to look after them face to face. And actually, that's okay as well. You don't need to go to the big hospitals for that either anymore, because you can go to our CATUs and you can go and stay there for a few days. And what we've got there is some really high-banded senior staff nurses that will do those observations. And if you do significantly deteriorate, then again, she's there to make sure. And because we've done all this, when we call the ambulances, they'll turn up because they're not sat outside to a risk. So that's a really short start. But essentially, advances in technology, advances in community diagnostics, improved resources in the community, ensuring that it's not just your primary care GP trying to manage all this, means that as we get more mature and better, we can coordinate, we can work out who needs to go to ED, who doesn't. We send out different cars to what you need. We can take you to an assessment in the community with all the bells and whistles, with the diagnostics, and then we can look after you at home with, again, increased technology, bells and whistles, or we can treat in the community if we need to. But all of this can also, if we get to the red and you do need the emergency, you can go straight into emergency. And all of this is done in close collaboration with our primary care colleagues and our specialists in the hospital to make sure that you can phone a friend and get some advice. So the only time you need to go to the hospital, when you get there, you can get them through the front door.
A couple of questions if anyone wants one. I know we've really
for anyone.
Well done. Just while we wait for confirmation that they finished in the main room. Did anyone have any questions they wanted to ask about any of the speakers?
Why is everybody on blood thinners?
Because the evidence suggests currently that if we thin your blood, we decrease the risk of stroke, and stroke is so catastrophic, it's worth the risk.
What else could we do?
Well, again, it goes absolutely back to your go back. Reduce obesity, reduce blood pressure, reduce stress, etc., etc. Yeah.
Come to a summer wellbeing festival, learn all the things you can do to get
Yeah, so all your lovely prevention stuff, green spaces, reducing stress, reducing high blood pressure, improving your diet, increasing obesity, etc., etc.
Hi, I love the idea, and I'm really for the virtual nursing at home. You know, we all understand that people can recover a lot better when they're at home than when they're in hospital. But we're from Saltash, and we just don't have that facility at all. And we know that if somebody's been in Derriford Hospital, you know, they can get discharged between 3 and 5 days. If they're a Saltash resident, it can be up to 28 days. We have no access to that at all, and we would be desperate for something like that.
I think they've just started working now with our virtual ward and Derriford's virtual ward, and there's a whole piece on the frailty virtual ward. And I think we had our first patient that came from the Derriford into our Bodmin SDEC and then back again to the north. So we are just starting that work now in those pathways. All of this is maturing at different rates, but Derriford are now almost where we have been on our frailty, so we would be able to offer. But give us another 2-3 months and we should be able to do the same thing.
Because we got like the redundant St Barnabas.
Yes.
Where before COVID, as councillors we used to meet and say, this was going to go on, this is going to go on there, and was COVID sort of stopped
on progression with moving forward, because our opportunity is going over the road to Derriford, where you don't want to, you know, with this sort of thing.
Yeah, we've mapped our Bodmin same day care, and we get an awful lot of patients from the northeast. So we get people from Tall Point, from Bude, everybody coming down, and the paramedics are very happy, and they would rather bring people to Bodmin than take them over to Derriford if it's appropriate.
But I think Millbrook are able to do more things in their GP surgery, aren't they?
Tall Point is very advanced. Yeah.
Tall Point and that area.
Yeah. I'm a Tall Point girl, so I keep these.
So there you go.
So.
Just quickly, what are you doing to be able to evaluate the projects in a way that informs funding? Because one of the things that quite often happens with these innovative things is that there's no value demonstrated hard enough and the funding gets pulled.
So the virtual ward is actually under observation or by University Exeter researchers, so they're doing a whole research piece. So the first bit has shown that it's safe, because that was the most important thing, that it's safe, that the outcomes aren't poorer, because again, that's the most important thing. So it's safe, the outcomes aren't poorer, and they're just continuing with us, because what people really want to know from the Commissioner, sorry Kate, is how many bed days are we saving and how much can we free up?
So that isn't what the Commissioners want to know. They want to know how many people continue to thrive and have a happy life rather than get taken into hospital, have muscle mass loss and a miserable rest of their days. So this for me is hopeful, because I'm nearly 60. I don't want what we've got currently. I want this everywhere. It should become our standard in Cornwall.
Neil?
How do you build confidence throughout all the touch points that make this happen? How do you get people to thrive on this new model and say this is the right thing to do? Do, for instance, ambulance crews get feedback as to the outcomes for people so that they know it was right to go to a sometimes it's easier just to get in the ambulance and go to ED. And we know that's not right for so many people. So how do you build that confidence so that this continues to thrive and doesn't stutter and fail? Because that's what's
this new service, brilliant, we've done our comms, let's move on, doesn't work. It is that absolute constant continual battle cry. It's being really, really integrated and really, really friendly. And we've got on our S-Decks and that sort of, hello crew, it's so lovely for you to come, have a chat, look, this is what we do, rather than just a drop off, do you want a cup of tea, you know, quickly while you're changing over and things like that. But it is a constant. We've also got some videos, some podcasts, we've got some sort of town hall type meetings, so we've got sort of a whole load of comms over the next 12 months to constantly reinforce.
And it's part of our job as well. So while we're here, what would be lovely is if this became a social movement. So my kids know what I want when I'm less able to articulate for myself. It will be this. Anything else that's offered, I'm not having it. So there is just something about how we get a little bit of people power behind what we do and what we don't want to have. And if a conveyance is an automatic gravy train thing, for relatives to know they can say, no, she doesn't want that, she wants this.
And all of this is vital, especially at 2 o'clock in the morning,
Absolutely.
that when the paramedics get there, the advanced care planning team, and they've been there before, and so that they are absolutely clear. What makes it really difficult is when that bit's not done, and then you're asking very new people to make those decisions. But where we've got our primary care guys going out with their Brave AI now, identifying those patients, doing all that advanced care planning, having those really lovely chats, you know, at 2 o'clock in the afternoon, hopefully outside in the garden, rather than trying to ask the family at 3 o'clock in the morning when someone's a bit distressed. So there's a huge piece of work that needs to happen upstream as well.
We've been requested to come back, but I know there are a couple of people who had their hands up who haven't had a chance to ask a question. I think you had your hand up.
Yeah, and very briefly to respond to the question about the evaluation. So the CATUs were evaluated by the Health Innovation Network when they first started as a pilot site, and that looked at the value to staff, as well as looking at the return on investment from a financial viewpoint.
Thank you.
Welcome, everyone. Welcome to our annual general meeting. We've got a number of points we want to get across beyond the finances. So as we go through here, I encourage colleagues to openly chat and discuss as you would normally, please. So good afternoon, everyone. Welcome to the Royal Cornwall Pavilion for our annual general meeting. If I can introduce the board, Sanj, if I can start with your good self, please.
I'm Sanj. I'm one of the non-executive members and vice chair of the ICB.
Martin Sykes, non-executive member of the ICB.
Emma Rouse, Cornwall Voluntary Sector Forum and VCSE representative.
Nick Kay, ordinary member of the ICB.
Steve Williamson, partner member of the ICB board, representing NHS trusts and foundation trusts, and I'm also the chief executive of Royal Cornwall Hospital's NHS Trust.
And Simon Davis, chief finance officer for the ICB.
John Gavert, I chair the ICB.
Hi, I'm Kate Shields. I'm the chief exec of Cornwall and Isles of Scilly ICB.
Hi, I'm Susan Bracefield. I'm the chief nursing officer and the chief operating officer at the ICB.
Hi, Chris Reed, chief medical officer for the ICB.
Hi everyone, Patrick Weir, chief people officer for the ICB.
Hello, I'm Neil Walden and I'm a non-executive member of the ICB.
The colleagues on the screen, we've got... Turn on this. Debbie, could you introduce yourself, please?
Hi everyone, I'm Debbie Richards and I'm the mental health department member on the Integrated Care Board and I'm the chief executive of Cornwall Partnership Foundation Trust.
Ali?
Good afternoon, I'm Ali Bullman. I'm the local authority partner on the ICB representing Cornwall Council and the Council for the Isles of Scilly, and I'm the strategic director for care and wellbeing in Cornwall Council. Thanks.
Kelvin?
Sorry, yeah, didn't quite hear that. So yeah, I'm Kelvin Hipperson. I'm Chief Information Officer for the ICB and also Chief Information Officer for RCHT and CFT.
Thank you. And Molly?
Good afternoon. I'm Molly Marcoux, Interim Company Secretary for the ICB.
Okay, so we have a number of apologies. Molly, I think you know who they are, so if you could take those, I'd be very grateful. And we'll move on.
Sorry, Chair.
Thank you. Yeah. Happy?
Yeah.
So...
we just missed one individual, Chair.
John, there's Hester's here from NHS England on the screen.
Yes. Not a member of the board, though. Welcome.
Okay, apologies.
That's all right, welcome. Okay, so I just want to do an opening introduction and address to you all, if I may, as part of our annual general meeting. So we're now 2 years old, can you believe? Our second AGM. I'm immensely proud to be here and to chair the board of the Integrated Care Board across the health and care services. Ultimately, we're here to serve every one of our citizens. Our AGM today is a time for reflection of what we've achieved and the challenges we've got and what we hope to achieve in the future. So you've heard this morning some rather interesting, I hope you find them interesting, new initiatives that we've taken, everything from the community response activity in terms of the X-ray car, the work on dentistry and lost withiel, right the way through to AI technology. And also in terms of the community health work, delighted to see Donna, and good luck in terms of winning those awards up in London, coming up fairly soon. We've begun together a really interesting journey of trying to put in place real 21st century model of care for people that we serve. But we need to move people and our services closer to people's homes, maximise the technology we deploy and the teams that we use, and invest further in preventative care. We've got to be careful that we don't just have this intention, we actually follow through on it. Collaboration is going to be at the heart of our new model that we've been rolling out for a while, but we'll continue to roll it out. And that's working across the entire health and care system. Our current membership of the board is made up of a variety of members, of which you've now seen. And also one colleague who's a statutory board member who isn't here today is Smitesh, who's looking after primary care and medical services. We have to drive towards understanding more of what our patients and our citizens want from us. And therefore, in the not too distant future, we'll be making, as we spoke about in our last board meeting, 2 associate non-exec appointments, actually, one of which will oversee, on behalf of the board, lived experience panel, And that will be feeding through directly into the board, along with the video vignettes that we do each time to understand more about what's people's views in our communities. We've got to do more in terms of equity, race and support for women, and calling out discrimination, abuse or bad behaviours wherever they are seen, and giving everybody who works within the system a real belief that we're actually going to tackle it. So we're going to renew our vigour in 2024 and 2025 to really get to grips with these health and care issues that our staff are facing. But just for a moment, I want to look back. I know you know I don't normally do that, but just for a moment, I want to look back in order to go forward. We all know the impact that COVID had on our services since March 2020. From my personal perspective, I'm sure you'll share with me, our collective staff did a phenomenal job, I would say heroically, against the odds that they were thrown at during the time. And it was an immense task to get through the epidemic and move on. But now we're in the period post the epidemic. There may still be some COVID around, but post the epidemic. Whereas we now have made, as an integrated care board, and pre the integrated care board, the CCG to be fair, Kate was the chief exec, made huge investments in the NHS staff working in Cornwall and the Isles of Scilly on the basis of staffing that we already had. And yet now we're facing a position where we have significantly more staff than we had compared to pre-COVID, with actually less in demand and activity going through our acute than we have now. However, it might not feel that way to our patients and to our staff. And therefore, we have to think about how we reorganise ourselves to actually get back to doing things in a fashion that will actually be more productive with greater outcomes. In addition to that, we have a new government. It's clear from what I'm hearing, unless other people have got some insights I haven't had, that it's likely there's going to be no more funding. And therefore, we're going to have to consider our commissioning intentions, which is what we were speaking about this morning, our commissioning intentions at our board in September, which is next week, and as we go through in October and in November. As a unitary board, we therefore want to ramp up our strategy of delivering services closer to home, what we call channel shift. We want to be more clinically led, and we want to have better outcomes for our patients. There's been other challenges that the teams have dealt with admirably, if I may say. Industrial action, other issues that they've had to face, and together we've come through that. And I'm increasingly made aware of the fact we don't just have winter in Cornwall, the Isles of Scilly. We have a seasonal pattern because as soon as winter's over, summer arrives, and then we have a whole church of people visiting us. So it feels like we actually have winter every day of the week. So we have huge pressures in Cornwall that some other systems don't see. We've got to move on to the significant and dealing with the significant inequalities and equity of healthcare that exist across our communities. It's not the same in one part of our community to other parts, and we need to deal with equity more than we have done today. We're making a difference, we think, and we're going to do more. And I want to share with you some of the immense achievements that the teams have achieved over the last year that support us. So if I can go to the first slide, please, Pete. Once I know it's up. Okay. There are some staggering numbers in here, and I just thought ought to share them with you and go through them, each one of them. Our GPs in general practice delivered 4 million appointments. We delivered 123,000 face-to-face mental health appointments, nearly 2/3 face-to-face community support activities, and 250,000 combined visits to our emergency department, urgent treatment centre and minor injury units. 800,000 outpatient appointments and nearly 160,000 hospital appointments, with roughly 2/3 of those for planned care. These are astonishing numbers. And when you consider we only have 600,000 residents in Cornwall, these are astonishing numbers. So what we know is that our primary care, GP practices, dental providers, pharmacies are the front door to our system and the priority for our public, and we need to invest in those more and as we go forward. Many people tell us of the challenges of accessing a general practice, a GP appointment at the moment. And we know there are differences in access depending on where people live. And what I'm hoping that this next infographic actually brings to life the support being offered by primary care partners. So Pete, if you can put the second slide up, please. what you can see here in the month of June is what our 57 GP surgeries dealt with in terms of scale. Over 1/3 appointments in our GP surgeries. These are astonishing 60% face-to-face now when you think about what it was during the COVID window. We've got a huge reliance on primary care in its wider sense, and therefore our system isn't just our acute or our Community Foundation Trust or our general practice. The system is the complete integration of all of these. And clearly we wouldn't be able to deliver a lot of this without our wider third sector and council partners both across Cornwall and the Isles of Scilly. So what these pictures show in the sheer number of people that are involved in both who we are supporting and the sheer number of services that we are delivering. I'm very proud that our teams and partners work together in the way they do now across the Cornwall and the Isles of Scilly, because our patients are at the heart of everything we do. Now, we don't get the chance very often to reflect, as we've done today, and I just wanted to reach out to each and every one of you and to your teams and say thank you on behalf of myself and the Integrated Care Board of those people delivering such services across our system. So I just want to take a moment to say again to you, thank you. So, if I may, I'll move on to the rest of the agenda now. Formally, colleagues, if you could just take a look at the minutes of the annual general meeting held on the 23rd of September 2023. Are you okay if I take them as factually accurate? Yeah. I don't think I can see anyone putting their hand behind me. No, I can't. So, Molly, if you could kindly record that, those minutes as approved. Before we move on, I'd like to just take 5 minutes of your time to actually get the team to actually show you a short video they pulled together. So, Pete, can you show the video, please?
So I think over the last year, the team that makes up the NHS in Cornwall has worked really well together. So the blurring of our organisation boundaries has got less distinct, which means that we are becoming one team working for all our people across Cornwall and the Isles of Scilly.
One of my proudest moments is how we as a group came together, worked on the things that really mattered, put our individual institutions to one side and thought about the patients and our citizens first.
Okay, so this year saw the development of the community diagnostic centres. They're attached to the urgent treatment centres, so Bodmin, Camborne and Redruth and Penzance. And that means that local people don't have to go to Treliska for day-to-day assessments or for diagnostics. Makes care much more accessible and gives a lot more choice.
One of the big strategy issues that I think all 42 integrated care boards have got to deal with is how they move support for patients and residents closer to home.
We put GP hubs in place, which means that on the day people had greater choices around seeing a GP, which means that our general practitioners were able to manage those of us with complex health conditions so that there was continuity of care. We plan to do more of that over the coming years, and we want general practice to be the bedrock of healthcare across Cornwall and the Isles of Scilly. We know that when you're older, if you get admitted to hospital, you are likely to lose muscle mass quite quickly, which means that when you go back to your own home, it's harder to look after yourself. So we're starting to put in place services that mean if you need an assessment, if you need an MRI scan or a CT scan, or you need to have some blood tests done, you don't have to go to ED.
As an ICB, we've got £1.4 billion of healthcare investment. With our teams across health and social care, we're able to have 4 million GP practice appointments, 800,000 outpatient appointments, 2/3 people are getting community health support worker initiatives. We've got 250,000 people going into A&E and into our MIUs. We've got 160,000 people having hospital admissions, of which 2/3, by the way, are for planned care, and 125,000 odd people being supported by mental health. This is integrated systems at work. In order to make that work, we've got the big infrastructures, we've got the hospitals, we've got the MIUs, we've got the diagnostic centres. Now what we need is to make sure we have the resources of our staff and colleagues and partners working in the right places at the right times, working on the right clinical things.
So there's this great phrase, isn't there? There's no health without mental health. And clearly there isn't, because problem solving, self-esteem, confidence, they're all part of our mental health makeup. And over the last few years, we've seen a big rise in people wanting to talk, particularly around depression and anxiety. Our talking therapy access is up in the first quarter of this year, and we're looking at different ways in which talking therapies can be delivered.
So I think there's a lot of innovation that we have to do to support people with mental health in a world where certainly my children have a completely different focus on it to the way in which I would have. Therefore, there's no one size fits all in this dynamic.
So over the last year, we've developed a strategy for end of life across Cornwall and the Isles of Scilly. Really exciting initiative with cancer charities, Macmillan and Marie Curie, and it just means that we can offer people at the end of their lives and their families support in the places that they live and convenience for them around the most important times of people's lives.
So I still think there's a long way to go on dentistry. So as part of our strategic review of all services for people, pharmacy, optometry and dentistry are key to our thinking going forward.
So oncology services in this county are amazing. We regularly get great patient feedback from using services. We also get great feedback from learners, so student doctors, student nurses, working in services in Cornwall. So we're very fortunate we've got Cornwall Health CIC, Community Interest Company, because they were set up by our GPs. They do vaccinations and screening for NHS England, but also really importantly for us, they do out of hours services, and they're starting to move into 24/7 services. So it should mean that there will never be a gap between your GP being available to see you, out of hours cover, and then linking into our broad range of community services. A big priority for us next year is looking at 3 long-term conditions that have got probably some of the biggest impacts on people's lives in Cornwall and the Isles of Scilly. So diabetes, respiratory conditions and cardiovascular services generally, which will include stroke.
And I think the challenge for all of us is we've made a great start, but the scale of the task is so big that we've got to find ways of actually cementing that problem with new ways of working, deploying maybe our resources in different ways, and listening more to what our patients and citizens actually want from us too. So at the end of the day, it's people that have to make this thing happen. And I just wanted to reach out and thank all our partners as well.
I am really proud at the level of enthusiasm and the vibe that's going through the organisation, the excitement around working together in different ways so that we can be great for our people across Cornwall and the Isles of Scilly. It's great to see that the leadership of Debbie Richards from CFT, Steve Williamson from RCHT and Ali Bullman from the local authority. There's a real determination, I think, because our collective desire is to serve our people well and to make sure that our population thrives.
Thank you very much, Pete. And thank you to Lucy and the team for putting that together. Thank you, Jenny. So can I introduce Kate Shields, our Chief Executive.
Thank you very much. So watching that, you just think, aren't people lovely? You know, some of those facial expressions on that video and just people being together, enjoying doing something that adds value is gorgeous. So the role of the Integrated Care Board, so our reason for being, is to make sure that people who live here in Cornwall and the Isles of Scilly get the right care they need at the right place at the right time. But we have to make sure that we improve the health and the health opportunities for our population, reduce inequalities and inequity, and spend our money wisely so that we get a better deal for those who are most vulnerable than we have maybe up until this point. We need to understand our communities so that we know that we're doing that. So whether you live in Bodmin or Bude, Newquay or Newlyn, Redruth or the Scillies, we know the needs of your local community. And we know the solutions to those needs will be different. So we need to flex with you. Sorry. For that reason, we're working with people who know their own communities. So probably not a lot of our statutory agencies, or many people in our statutory agencies do know their communities, but people who live and work in the places where people live around Cornwall and the Isles of Scilly. We want to build on the strengths of those communities, their understanding of what works best around here, and making sure that we're giving people what they want and need. Over the next year and going forward over the years to come, we want to make big important changes and respond to what our residents have told us. And last year, Lucy and her team spoke to over 10,000 people. I had a bit of an argument with somebody over the weekend about whether it was technically possible to speak to 10,000 people with a small team, but it is. The dedication they've put into making sure that we have a whole variety of different channels of communication, speaking at face-to-face events, at support groups, receiving views from people from online surveys. And those people are consistently telling us what they want and how they want to receive it. So they want easily accessible 24/7 services, where the standard is the same in the night as it is during the day. That there's an equal access and an equal availability of physical and mental health services. Oops. That we dig deeper into a person's health problems to find out the root of the problem of a holistic solution. We don't just take the diagnostic label that's attached to somebody. That we offer kinder and personalised care. And we empower people to look after their own health and well-being because they know themselves better than we do. They're asking us to provide personalised care based on what they want, not the assumptions about them or the assumptions about what they need. Now, I know for many of you that won't be a surprise because you'll have heard all of these points before. But isn't it sad that consistently, when we go and ask people, we get the same responses back? That our services aren't consistently kind now. That our services aren't easily accessible like many high street services are. But we need to listen and we need to do something about it today and in the future. And I think we've started responding to some of those needs. But over the coming year, and the coming years, with John's message around we aren't going to see huge uplifts in money. We are going to have to make sure we focus our resources on the people that need that resource the most. We are going to have to make sure that our services aren't duplicating. They are coming alongside each other for a continuation of service across many points of delivery. That is our challenge. As our community workers expand across Cornwall, this local delivery is starting to become a practical reality. I was thinking when Donna was presenting earlier that we've got nearly 50 community well, thank you. I want to say community development workers, community wellbeing workers. But that's not going to be enough, is it? And if you think about where we've chosen to put money over time, we might have to start thinking about the building blocks of life and health in Cornwall and making care as simple as possible. So if I need my clothes putting on an Aira for me when I'm older and I can't do that anymore, is there going to be somebody that will help me, or will that become a health-related need that will take me into a hospital where my issue isn't solved, but somehow I get something that somebody else thinks I need? Those small gestures, by being there at the right time, can reduce the risk of a fall. I was watching the 15th Health Symposium on falls over the weekend in India, and their message is you don't have to fall when you get older. You just need to be supported to live well. And those messages through our communities, we can stop hospital admissions, we can stop attrition, we can help people to live with frailty happily in their own homes. We need to support people for their cancer screening. Why have they missed an appointment? Why haven't they turned up for the screening that was arranged for them? It's life-saving. What are the obstacles to that person accessing preventative care, diagnostic care when they need it? We're now in a position that we can give our residents more choices than they've ever had before to have care close to their homes. And I'm saying that carefully because I know we have had lots of initiatives and embedded programmes across Cornwall and the Isles of Scilly that have started to do this in small pockets, in small places over many years. But I think we are at the point of being able to mainstream that, mainline it across the whole of Cornwall. We've got diagnostic tests available in our Community Diagnostic Centre at Bodmin, and this autumn a new elective surgical hub opens in St Austell. It'll cut the waiting times for people accessing elective services, but it also means people don't have to travel the distances that they might need to travel to access care. We're working to provide more services at times that are convenient and more local, rather than expecting people to come to us at times that maybe don't work for you. If you've got a 0 hours contract, that you don't have your own transport and you've got children that are in school. But that will mean that our colleagues, our staff groups across Cornwall and the Isles of Scilly are going to have to change the way they work so that they can provide the convenience to our people who need to have it made available to them. Like the health checkups and tests we offer at the harbourside to local fishing communities who often struggle to attend appointments due to working commitments, we need to think about those other working groups who can't access the care that we should be offering during the times that they're available to receive it. We've begun some really exciting work with women's health hubs, bringing integrated healthcare services to women across the Duchy. And we make no shame that we're starting off those health hubs by focusing on the women with the greatest vulnerability and the greatest need for integrated access to services that are bespoke for them, maybe sometimes with their children, so that it's easy for them to attend. They're designed to offer more advanced care than a general practice, and where a hospital referral may not be needed. The hubs aren't limited to a single condition, so a woman can have a cervical screen at the same time as having discussion around contraception, or maybe just life. This work is helping us to tackle the many inequalities that still exist for our people. But it's only a start, and there are so many things that we need to do. It's been wonderful to see the progress we've made over the last year, but of course there continue to be challenges. There's still a gap of life expectancy between our communities. The size and shape of our services isn't what it needs to be to meet the needs of our population. And by that, I mean that I think over the last years, we have maybe put money where it seems like the loudest requirement is for the money to go, rather than the greatest return where the money could be placed. And as we go over the next few years with no more funding available other than flat cash, there's going to be some really difficult decisions for us to make as a board and for you to hold us to account for making for our communities. Too often we use our emergency department to provide care that could be given better, closer to people's homes, especially the end-of-life care. So we still have people going into our CHT's emergencies department and University Hospital Plymouth emergency department because pain relief can't be given to people during nighttime hours. That surely can't be a good way to provide care for people in their most vulnerable times for them or their families. That's why we're expanding our services outside core working hours so they're available when people need them, in the middle of the night, when you're frightened, when it's dark, and when you're not quite sure who to speak to. You've heard about these services and the difference they're making at the presentations earlier today. And we must do more to improve health and wellbeing of children in Cornwall and the Isles of Scilly, so the debate we had around starting well. We have dental education programmes underway with supervised toothbrushing within schools, but we want to go further. We want to expand some of the great mental health support and focus more on the pathway for children with autism and children with ADHD. We know we've got a lot of children waiting for an assessment, and part of our work over the next year is how we can support people to wait well, acknowledging that we have a lot of people waiting to be assessed formally. Workforce plays a vital role in everything that we do. And our workforce isn't confined to doctors, nurses, psychologists, OTs, physios. I'm trying not to miss out a professional group. But those people that work within our hospitals, our health centres, our community teams, our workforce is much broader than that. It probably touches on every family across Cornwall and the Isles of Scilly, because we will all have a contribution to make towards health, care, support for our people. So this year has been a time of change. Within the ICB, as nationally, we've been asked to reduce our running costs. Our people, so people in this room who work for the ICB, have been through a really difficult time over the last 3 years. 3 years of uncertainty, really, as they were waiting from a CCG to seeing what an ICB would be. And then 2 years of the ICB being established and us saying we're going to restructure and we'll lose 30% of our running costs. So I just want to thank our people for bearing with us, staying with us, as somebody said to me the other day, seeing this through to get to the point where we are in the right shape. We are in the right shape to help address the size and shape of the services that we're planning and buying. So together, we're developing the ICB to be an exciting place to work with a clear mission. Debbie, Steve and I went to a meeting in central London with Wes Streeting on Tuesday of this week, and he's really clear that we are a mission-based healthcare planning. So we're going to be moving from, I've written this down and I can't find it, which is really sad. We're moving from hospital to community. That is our plan. We're moving from analogue to digital. That is our plan. And we're moving from illness to prevention. That is our plan. And together, for our people, this ICB, I thank you for the work you've done last year and this year. And for next year, I'm very excited to think about what we can achieve together.
Good, thank you. On the board, are there any questions you would like to? Thank you. So are there any questions from the board that you would like to ask Kate? No? Can someone peer behind me? Any hands up? No?
No.
Okay, thank you. So before I turn to our Chief Financial Officer, now last year I gave you a challenge. And you surprised me with a poem. Am I expecting anything this year, or? No,
very serious this year.
Very serious this year. Okay, fine. So can I hand over to our Chief Finance Officer and the annual accounts?
Thank you, Chair. I'll start with a brief update. Obviously, there was a challenge of doing a little bit of poetry, but I didn't feel that was appropriate today, except for the start. So I thought just at the start, we'll try and think about what are the key messages, in particular from the accounts, to get across to colleagues around the room. So hence my delay earlier. I have prepared a very brief statement. It's not for the police, it's for colleagues here. Absolutely. So this is, I've called this the plaudit from audit. I thought that was a good start. So we got the result we wanted as a system, and we go from here. So it's that time of the year to say, Cornwall, well done. For within our 23-4 budget, all our services were won. The message from audit was short and sweet. The accounts were on time and the national deadline we did meet. But as Chief Officer with no hair, I'm delighted to report from audit our accounts were fair. In preparation, no information was submitted that was overdue, but most importantly, audit colleagues also reported our accounts are true. We're nearly there. What's most important to us looking ahead in 24/5, delivering best value we'll still need to put to bed. But now is the time to enjoy all that we've done with the work of our organisations and the services that they have run. So that was my brief little starter for 10. I will add some other comments. So, and I am going to put out the challenge for next year. So that the challenge for 24/5, we will all know, is to deliver amazing services, improve and deliver within financial balance from my perspective, and CFOs and chief executives of our organisations in 24/5. So my challenge is obviously to come back here next year, report success, and I'll lay out there for colleagues in the other organisations, particularly my CFO colleagues that are not here to defend themselves, that they start preparing 12 months in advance for a wrap statement on the position in terms of the accounts. Just to add a little bit of I would like to add, in terms of this year, working with across the finance system, Ian Dean was appointed as CFO RCHT, which I'm delighted with, and he's worked well and continues to work well with me and Adi Perry as the CFO at CFT, Community Foundation Trust. And I think, as you know, in difficult times, those relationships are most important, as well as they are across the different layers in our system. So I'll also say that is very important, and yes, we've got a brilliant bunch of colleagues to work with. So some key messages. You won't get any more poetry now, but some of the key messages from the numbers, and I'll take, obviously, the annual report and accounts as read, which are all prepared in line with audit requirements and signed off by audit. But the really successful things for us were £150 million accumulated debt was written off for this system at the end of last year as a result of 2 years of achieving financial balance, although we've achieved financial balance as a system for 3 years now. So we tend to forget that, but actually it makes a huge difference to us, and that isn't the case throughout every system in the country. So it puts us in a much stronger position going forward. And we generated a small surplus as an ICB, as did each of our organisations. So we met our break-even requirements in 24/5, and that was a significant achievement. And what I'd like to add to that, whilst we're focusing now on 24/5 and delivering against our current budgets, which is massively challenging, it's also now the time to build on the experience of the last 3 years. And it does feel that this is a turning point for doing both the two things together. So we talked about channel shift and the movement of improved care across the system, and also delivering it within a financial framework which is entirely sustainable into 26/7. The next 6 months is important to us, but I think now is the time to focus on that. So I will say that, and I have confidence in my colleagues working across the system, despite the challenges we have working with each other at times, because it's a difficult environment, that we can do that. So I'm looking forward to getting to the position that we have a wrap session at the end of this year. So that was the slight link. And the other thing to note is, in terms of allocation from the centre, as part of our, I can't talk about our size of our allocation because that's part of a little quiz next, but as part of our allocation, we were delegated from NHS EI a dental pharmacy ophthalmology budget of additional 66 million, which is we manage now either directly or through hubs that are managed throughout the southwest. So we have an additional allocation that's directly our responsibility, and we're all very aware of the issues and challenges and motivation to get services like dental improved in 24/5 and going forward. So that sits directly with us, and I think that's a very positive thing. So in terms of the money side, that was all I was going to say, but happy to open up to questions. And again, colleagues would have read the annual report and been through the people would have been part of the stakeholder event earlier, which unfortunately I wasn't, but I'm sure many of the issues and benefits of 23/4 were discussed there, and I'll stop there and open up for questions from colleagues. And then I think we're going on to a session just to test colleagues on their knowledge of the numbers.
Thank you. So before I open up to the whole board, can I go to our accountable officer, Kate?
Thank you. I think it is just worth reflecting on the work that's gone into delivering a break-even position across Cornwall and Isles of Scilly over the last 3 years. And it isn't the work of this board in isolation that's delivered that. So working with RCHT, CFT, with our local authority colleagues, we have put Cornwall in a position that it hasn't been in before, and we would like to keep it in that position as we go into the next few years. So there's nothing like building on success, is there? So I just want to thank Simon and his team, but I also want to thank the broader constituency of health and social care in Cornwall and the Isles of Scilly. Working together does appear to have much greater benefits than working separately.
Thank you. So I'm going to go up to the members of the board. Are there any questions for Simon? Somebody wants to shout at me from behind. I don't think so.
Susan would normally ask where his abacus is, but
There
she's
we
very
go.
polite.
Very good. Well, if I could just endorse really your point there about this is a real system and team effort. I think without that approach, having watched it through the year, it would not have ended up with a phenomenal success for the third year it's been achieved. So thank you to the whole system, and thank you to your team, Simon, and to you for keeping us on the straight and narrow. Okay, so Molly, from our perspective, we are effectively approving the annual accounts, yes? And annual report. Molly?
Yes, Chair, we are. We're adopting it. Sorry.
You're okay, yes?
Yes, Chair, we are. Can you? I don't know if you can hear me okay.
Yes, we can. Thank you. So we've effectively approved the annual report and the annual accounts as a board. Lovely. Thank you very much. Yes. Thank you. So I'll move on if I may. Now this, a bit more interesting bit, I hope, for some of you. We got the roving mic. So yes, before we just kick on, I'm conscious that Kate has to step out at 3:15. We can continue on afterwards if you get the energy going and you want to ask those probing questions of the board. But if you can possibly think of anything particularly you want to ask Kate while she's here before 15:15, I'd be very grateful. So if we can open up to the floor, any questions that anyone would like to ask the board? Or the detail of the annual accounts? Go on, I dare someone. Page 42, subparagraph 9. No? What did you think of this morning, by the way? Any reflections on that you'd like to share? Never known you so quiet.
The carb slump.
There were no carbs.
Big couscous.
We have a question from Mike. Thank you. How do we factor in climate resilience discussions, and how do we leverage all of that stuff
to help us deliver on all the other challenges? The spoiler alert is we can do that. I just wondered what the board thought.
So that's my starting point. So clearly, I mean, you just look at our summer. So if people don't think the climate's changing in the UK or in Cornwall, I don't know where they've been over the last few months. So clearly there is stuff we need to do. You are doing massively great stuff with primary care, and I know across the county, and I know that RCHT and CFT through their built environment are doing amazing work, and they've got some real climate activists working within our secondary care services, but also within primary care. So I think it's how we bring all of that together. So we need a plan. The plan needs to be multi-year, and it needs to cut across all of our strands of investment. I think our stated strategy around you shouldn't have to travel for stuff that you can get near to where you live in itself is helpful because of the size of the county and the carbon footprint of having to travel from one place to another. But that's just the start of it, isn't it? So, so yes, a conversation to be continued.
And when we spoke this morning, when we were in the drawing phase, for those of you here this morning, our table had a great conversation about the wider determinants of health. And while I've got Ali Bullman on the screen, and I can see some of our council colleagues here, I think this is where it becomes really important that some of these things are joined up at the integrated care partnership level, because this is where all the system partners, both Cornwall Council, the Isles of Scilly, Council for the Isles of Scilly, the NHS in its wider sense, with the third sector and the wider partners. Some of these things we can only do on the wider health determinants by working with partners rather than doing themselves. I think that was a great conversation. And that leads us not just to work out what we're going to do this year. It'll start the discussion about helping the discussion around 24-25's commissioning intentions. But also, if you think about it, we're going to start looking towards prevention, which is the key theme you injected this morning. We're going to think towards prevention going forward as part of our medium-term financial plan. We have to carve out space now to actually do things that we say are our priorities. We can't get to a position where we want to do them and say we just can't find the money to do it. So there are going to be some difficult challenges, some difficult priorities we're going to have to find. And that's going to have to start coming through to us over the next few weeks and months. So thank you for that.
Can I just add?
Yeah.
So I think one of the roles that the NHS could have whilst we're waiting for primary prevention to start to bite is that we are able to demonstrate and describe the impact of not having that primary prevention. And I think while we're in that changeover of where money goes for housing, education, transport, self-esteem building, confidence building, there is something around how we use secondary and tertiary prevention to slow down the causes of ill health. But to be really clear, for some of our communities, they are way further ahead than others, and that our focus has to be on them over the coming years. So it's a multi-stranded approach, isn't it? But one that I'm sure that together we can make a big impact on over the next few years.
A question?
Sorry, John, can I come in?
Yeah.
Ali.
Oh, sorry, Ali, go for it, Ali.
Yeah, no, lovely. I just wanted to echo the sentiments of what you and Kate have said there. And Helen Keller, who's a deceased activist in America, once said, "Alone we can achieve so little, together we can achieve so much." And I think that really underpins the partnership work in Cornwall. And I just wanted to say that the council, the public health team, adult social care, children's services, and all our services that impact on the broader determinants of health are absolutely committed to getting the better outcomes for our residents and working in partnership to do so. So here's to the next year working in partnership.
Ali, when you and I met with Kate Shields and Kate Canally and other senior colleagues, probably one of the best collegiate meetings I think we've seen, certainly since I've been down here. So I wanted to thank you for that and going forward. I want to invite some colleagues from, I can see quite a few people from the voluntary and third sector here, if I may. Oh, so you want to ask your question first, sorry.
Can I just ask you, in these critical financial times, that you're going to support the voluntary and community sector in your partnership work into the next financial year? Because it's critical that the voluntary sector has financial guarantees regarding its work in the future.
Thank you, Mark. I was about to actually, thank you for that question. I was about to try and bring in Emma and Ian. So, Emma, why don't you give us your view, please?
So I do quite a lot of work across the South West region and have links into national ICBs, and I have to say my reflection of being a board member for 2 years is that there aren't that many ICBs that I hear who are making such a stated, ambitious commitment to funding voluntary community and social enterprise sector. And we've already heard some of the exciting work that's already commissioned by the ICB, and some of it jointly commissioned with the council, which is great, and we want to do more of that. But I'm really optimistic as the VCSE representative that we're going to be doing more. We had a really interesting example just this week where Manda and colleagues and I have been working on a much bigger prevention piece, as Kate was saying there, around diabetes and long-term conditions. That's a suggestion that actually that service is delivered by the voluntary and community sector, and there's real appetite across the board to really invest in that kind of preventative work, because we know in the sector that we often know our communities best. We've got organisations, small grassroots organisations, who work really closely with local people and communities of place and of identity, and I'm really reassured and optimistic about the board's commitment to that over the next 5 years.
Thank you. Ian, what's your take on it?
I think we've come a long way, and I've been around quite a while now, as you can tell by my demeanour. But I think we've come a long way over the last 10 years. I think those who've been around a while remember Living Well, and the community health wellbeing workers is not that dissimilar to what we were trying then. And I think the system at the time wasn't receptive to that change. I think it is now. I think the biggest area I see we've got to work on, and is worth our three ICA directors, Derek, Trevina and Juliet, is neighbourhood teams. How do we work in place in a different way to hold us to account for the outcomes for that population? We don't do that enough, I don't think. So it's how we do that, and not institutional KPIs, but the outcome for the people themselves. So I think the place working with Patrick and the workforce committee is pretty crucial. The other thing I would say is what we mean by anchor organisations as well. For instance, working with Donna for the community health and wellbeing workers, we made sure that all the workers were from the communities they lived in. There's 50 people who live in those communities, who can influence those communities. So my challenge to NHS is, if you have workforce who aren't clinically required to have a clinical background, how can we enable them to be employed and worked in the community they work in? Because that will build resilience, and that is an anchor organisation. And I see the conversations now that can happen. That wouldn't happen 5 or 6 years ago. So, thanks.
Yeah, so two thoughts. I'd like to bring Debbie in, so I just want to put her on notice. So we know we're going to have to deprofessionalise some of the things that we do, because professional bodies have brought things in to be special. We do this is our work. But I think, Patrick, is it by 2030, every single school leaver who leaves, is it 2030?
Let me see if I can remember this stat. So this is across the Southwest. In the next 15 years, the size of the working age population will increase by something like 57,000 people across the whole of the Southwest. And for the health system to maintain its delivery as it does now, we would need 60,000 people joining the health system over that time period. And clearly 57,000 people aren't going to choose health and care as their career, which illustrates the scale of that population challenge.
So even if we wanted to do it, it's not possible. The size and shape of healthcare, we know where we put our money at the moment, and the services we buy probably isn't meeting the greatest need, that we need to move things around a little. And then we've got gorgeous examples that I'm hoping Debbie's now going to tell us about, around people in communities that didn't want to work with us because they didn't like us very much, having a recruitment campaign that's led by somebody from the community. We've now got people from that community working with us. Debbie, can you fill in the gaps?
Yes, absolutely, Kate. Thanks for handing me the mic. Can you hear me okay? Yeah. I'm going to plough on. So there are several things I'm really proud of that we've achieved over the past year, and we want to build on in the coming year. So focusing on our partnerships with the voluntary and community and social enterprise sector, We're working really closely with Cornwall Health CIC to the benefit of local people across the county, and we're going to be building on that further in the year ahead. But also, in addition to the contracts that the ICB has with the VCSC, CFT itself has several contracts with other organisations, including Volunteer Cornwall, including Pentreath, and so many more. And they are invaluable contributions to our overall system efforts of delivering the best that we can for our residents. And we absolutely recognise that the workforce that our VCSE colleagues bring to this endeavour is actually really rich, really experienced, and our service users report really high satisfaction rates, and it's fantastic to see what's been achieved. And then in addition to those direct relationships, we're also working indirectly with organisations that are commissioned by others, but we are there to ensure that those services are integrated. And Kate and I have seen some fantastic examples today of things that are happening in our communities to provide better support and an alternative support to secondary care mental health services for those that need it. And we've also done some great micro recruitment across the county, and that's really helped us bring in local people into local jobs and to develop our workforce. And we often do some of our local recruitment with sometimes the local authority, sometimes Rural Cornwall Hospitals Trust, and other times the VCSE as well. And we have grown from what was known as the Clays project, where we had one very energetic and innovative young woman in HR who said, "This is my community, I know my community well, can you give me a tiny budget and I will go out to community halls, shops, and speak to parents at the school gate." And we actually had a really good uptake of people wanting to come into development roles and apprenticeships. And that has now scaled so that we have 3 development workers, 1 for each integrated care area, and they have continued those local connections which they hold in people's places rather than our health places, to actually continue that dialogue with the community and also see what workforce opportunities we can offer. We've also majored on our partnerships with the 2 major colleges in Cornwall and the Isles of Scilly. And in the last year, we've seen a fabulous simulation suite open in Bodmin, which is not only just set up to provide nurse training in simulated ward environments, but the latest innovation has been to also set up an innovative simulation suite for home care environment. So I'm rather hoping, Kate, that I've been able to respond to your challenge and do it justice and provide just a little bit more colour as to some of the work that we have been leading on to diversify our workforce across health and social care, including the VCSE.
Thank you.
Thank you very much. Can I invite Steve? Would you like to add some words from your perspective?
Yeah, that's okay. I'm really struck by Kate's comments. And Kate, if we think of a couple of the examples of things that are happening right now that are perhaps trailblazing or framing what that future might look like. As a system, we established a frailty same-day emergency care centre at Bodmin Hospital, which was then mirrored to establish a same-day frailty emergency care centre at West Cornwall Hospital, designed directly to provide care close to home rather than patients unnecessarily coming to the emergency department, so they can receive more rapid care from a workforce designed around their needs. So really, really powerful examples of what we mean by care close to home. And then if we think of the innovation of the X-ray car facility that we all heard about today, an amazing transformation that provides that access in people's homes in a way that previously patients would have had to come to the emergency department, and for some of them that would not have been required, and that is an impact and imposition to them and creates an additional pressure for those emergency care services. So really powerful examples of transformed services right now that are great examples of the kind of roles we might want for the future, which are those roles in the community. And even the elective surgical hub at St Austell, the recruitment there is determined to find a way to create those opportunities for local people, as well as delivering care in a local setting where otherwise you might need to travel to Plymouth or to Trelisk for that surgical experience. So right now we've got some amazing examples that are already being delivered that I think frame that opportunity for the future.
Thank you. Before I continue asking the board some questions, anybody else would like to ask the board any questions? Yes, you go first. Oh, sorry.
Yeah, I'm the chair of a patient participation group, have been for a long time. I've been interested in, throughout today, which towns have been mentioned. And I'm in southeast Cornwall, let's leave it like that. The nearest town I've heard mentioned is Bodmin, also Launceston. I don't know what the, what the distances are. But I'm wondering whether we are really, and South East Cornwall is getting its fair share of consideration in this. The only thing I saw in South East Cornwall was a tiny picture on one of the presentations of Pentor Health in Torpoint, and in Saltash, where I live and I'm a patient, we love something like that. We've had no investment whatsoever over the years. And, you're extolling care closer to home, but, we would like to have our share of the cake. I'd really also like one of your board to take an interest, because nothing will change unless there's leadership from you on the ground, and you feel very remote to us, that we don't know how to actually engage you and get ourselves in the plans. And just one little fact, sorry about this, folks, bit of local information, just one thing. Our work trying to get the investment and change in the town took us to Derriford Hospital. Derriford Hospital showed us the figures for the length of stay of patients in the hospital. If you lived in Plymouth, if you lived in Devon, you were out of there pretty damn quick, whereas there was a massive lag on discharge from Derriford into Cornwall. And that affects patients and their families very badly. But it must, I'd say to your finance officer, affect the spending of money. Extra days in the hospital, which could be spent, I would say, that money, instead of paying Derriford, spent in the community. And we're great fans of the idea of care closer to home. Thank you.
So bear with me just 1 second, Kate. I just want to bring in a couple of other people first. So, Neil, there's something here about the integrated care areas that we've got, the work that you're leading on that front. I can't quite see everybody with these glasses on in the room, but we've got 3 place directors. Hi, Trafina, sorry, I can't see you from here, actually. We've got Trafina, so I'll ask Trafina in a second. But Neil, why don't you kick off and explain the 3, but particularly the east side, and then we'll bring in Trafina, who looks after that.
So we have 3 integrated care areas with very much the underlying intent being care close to home. And if it isn't apparent that the work is happening where it needs to happen, that's a concern and would be picked up through our integrated care area teams, and Trafina is leading for the east of the county.
I'm aware, though, that the concern you mentioned second, if I can take that point, with regard to discharging patients into Cornwall is something that has concern for Derriford, and that their outreach team are looking at that very issue at the moment, and I hope that's something that you will get to hear about. You have, good. Okay, so it's not solving all the problems, but they are aware of it, and it is something of concern. It's not for me, I'm not operational, I just happen to chair an ICA committee at the moment, but it may be that you would want to link up with key people in your integrated care.
Let's bring in Trifina. Trifina, what are your thoughts? We can't hear you.
Really glad that Peter's here and he's ready. This is what happens at East Cornwall. So yes, I think really well-made points. I'm really excited about what we can achieve over the next year. Within the last couple of months, we've already seen some changes being made at Derriford Hospital. So we have brought in the STEP service to support discharge from the hospital, and we were able to do that really quickly. So I think by working together with colleagues like yourself and others in Saltash and the area, we are going to make a lot of progress over the next 12 months.
Move on.
So the Mayor of Saltash has already nabbed me, so here in force, and we have been having discussions with Derriford around mobile diagnostics, which there is a debate about whether it's needed or not in Saltash and Lou, so we mustn't forget that other fairly large population of people. We are talking, so Armand Toms, who's one of the councillors for Lou, is very vocal in this area, that we talk a lot about the west of Cornwall. What about the southeast and the north of Cornwall? So there is a lot of lobbying and reminding us that there are populations who feel adrift. So we are wanting to work with you to work out what works for you, but that means that, so we won't have a CT scanner or an MRI scanner because we wouldn't use it enough. So we need to be really clear what we've got at Bodmin and how people can get to it and back, what we can have in the community, so point of care testing, and then how we link in with Derriford so that people aren't stranded in a hospital when getting people home faster could work. Our new models around frailty, we're working much closer with Derriford now than we ever have done before around getting people home, and I think there's going to be some very exciting different virtual ward offer for South East Cornwall than possibly for the rest of Cornwall. We might be learning from that model rather than the other way around.
Okay, thank you very much, Kate. So let's move on. Yeah.
Thank you. So one of the questions I've got is it takes time to embed new initiatives, and particularly it's really difficult when the funding is given in a piecemeal way, because we're actually taking time to change cultures, change workforce, get sustainable workforce, and then embed that change. Are we able to get to a point where we're going to be able to look at funding in a more longer term perspective, so it's more than just a 1 year piece? Because actually if we just keep doing it on a 1 year basis, and I'm thinking particularly about the primary care hubs, we're trying to shift a model, change that to enable general practice to be more proactive in care management by siphoning off some of the activity and making their days a little bit easier. How can we get it more sustainable so that actually general practice can really move and embed that model?
General practice has to be the bedrock of access to care across Cornwall and the Isles of Scilly because it is the only universal service. It's where we register. We don't just pop in and out. We belong somewhere. We've been really clear as a board that the primary care hubs that we put in place last winter are the start of a hub development across Cornwall and the Isles of Scilly that seeks to enable Steve and Mark Hackett's staff from Plymouth and from Trelisk to come out of the hospital and to provide specialist care in the community with GPs and people like us who access care. During this financial year, we are making pre-commitments. So when we start coming to our commissioning intentions for next year, we need to be really clear we have to invest in those services, because the bedrock will then allow other things to grow. And I think you are right around longer term funding. But the reality is, once we invest, it's recurrent, because we won't be able to remove it, because we will have people going to it. It will change. I'm a bit nervous because we talked about channel shift and nobody knew what it meant. So I now feel like I need to be really clear around size and shape of services. Most people don't live in a hospital, so we need to be putting the services where most people live. And our hospital is the episodic place where you go to and come out of again because we've cured you, or you've got a long-term condition that's managed somewhere else. Our service infrastructure needs to reflect where people access care. Simon might want to comment on the future years funding.
I'm not going to guarantee it, obviously, but yes. The answer is we have been together, and it's part of what will go with the commissioning intentions, etc. when they go to the board next month, is to better articulate how we might move resources around and make that longer term commitment. So recognising that the better value care can be delivered in the community. How do we do that in a sustainable way? And so if I give an example, this isn't a service example, but a money example, we spend every year as the NHS, not just in Cornwall, but across the country, relying on what we call one-off sources of funding to support business as usual. So one of the things we want to do is to drive out that reliance, and therefore you've got non-recurring sources of funding to support change. We're not in that place at the moment, but that's where we want to get to. And certainly over the next 18 months, we want to be in a position where our prediction of how much resource is used and where it's used is much, much clearer. So it feels like we're at a point of change that we're working through that's really hard at the moment, because it's always been a demand from that organisation to that organisation in terms of shifting resource. But the dialogue is getting better, and I think the mechanisms for moving resource will be a lot clearer over the next 6 to 7 months as we plan into 25-26. So,
thank you.
Thank you.
Yes, next question.
Hi, I'm Chris. I'm a community pharmacist in Cornwall. Simon, you mentioned earlier that next financial year you've allocated £66 million of additional funding for dentistry, pharmacy and optometry. What proportion of that would be for community pharmacy, and what shape will that funding take?
Just to, I can't answer both parts of the question. What I can say is it's a movement of the allocation from NHSE executive. So it was managed pretty well centrally before. It's now been passed down to us. There are, within the 66 million, some additional funds, but it's not an additional 66 million. But the plans for how that's going to be managed and directed will come out over the next 2 months as we share commissioning intentions, etc., etc. And we're always keen for people to be engaged in the dialogue for constructing those. Thank you.
Question. I'm sure the ICB is aware of the huge pressures in community pharmacy nationally as well as in Cornwall. And more pharmacies are looking likely to close in the next few months in Cornwall. This is going to create an additional pressure on the existing pharmacy network. Is there any interventions planned by the ICB to help the pharmacy network in Cornwall so that we could stay afloat?
Okay, well, do you want to respond now?
So I can't see you, sorry. Clearly, we can't do without pharmacies, can we? Because Pharmacy First is a really clear strategy that the NHS will be relying on as we're looking at the development of place-based services, that with general practice being the bedrock and the services around it, providing that choice. So one of the things Susan and I have just been whispering to each other is, in terms of our development plans with our integrated care area directors, we should be making sure that pharmacies are a very clear part of that. So I won't say, yes, we have a plan. We need to develop one. Do you know who your placed director is? Yeah, so Juliet. So we're writing a a response around some very specific things in St Ives. But Juliet, in terms of your place director, is the woman I would nab if I were you before you leave the room.
Okay, and just before we move on, what I would say is there's no point taking what we've done last year, photocopying it, replicating it next year, because we're not going to do any shifting of the dial of resources if we just do the same. So we're just about to go through that process of unpacking those exact questions you're asking. Next question, please.
Kate, I know you have to go very shortly, so we'll just move on.
I'll try and make it very brief then. Hi, I'm Rebecca Whitting. I'm from the Health Innovation Network. What I have heard today, and it's been a real pleasure to be here today, so thank you. What I've heard is a really ambitious strategy from the board, and it's been great to hear that it's a multi-year strategy as well. It's driven with the person at the centre, and I hear that people on the board have really got that at the heart of the decisions that they're making, and amazing to hear that you have managed to deliver a budget on time. From an external partner viewpoint, I think that there is a continuous challenge between balancing prevention and dealing with the firefighting of delivering great care on a day-to-day basis. But I just wondered, I don't feel like we've heard from your non-executives who I hear, I think hold a really key part of your board. They get to speak to you far more regularly and they hold you to account in a way that an ADM potentially doesn't do. I wondered whether we could ask the non-executives whether they have any reflections on what they think the challenges are operationally for your executive team over the coming year of trying to balance the really significant challenges that they have got of trying to deliver operationally on that really ambitious multi-year strategy.
Neil, non-execs, but what are your thoughts first?
I'm going to be completely honest with you. When I came into the ICB 2 years ago, I'd been retired as a GP for 3 years, but I had been embedded in the idea of integrated, preventative, person-centred, early intervention type work for many years, and I won't say I'm completely happy that this is, I'm very happy this is happening, but I'm not completely assured in the sense that the operational pressures of double running, especially with the elderly population we have in Cornwall, are really quite extreme, and balancing that for all the people involved in the whole system is a difficult thing to do. But I am now seeing an undertaking with clarity as to how we're going to achieve this, and I feel confident that the next 18 months will see the shift that we need to, because it's not just about managing figures and data and everything. It's about doing the right thing for people, and the right thing for people, particularly our frail elderly population, is to serve their needs close to home, and to see the advent of the SDECs and the work happening at certain parts of the county with others to bear in mind is heartening, because I'll be honest, I didn't think I'd ever see it before I finished this, and I think I will, and so I am, with the proviso that we do need to be thoughtful about how the impact of shifting resources is, and that's something that's a constant dialogue and a constant worry.
So I'm going to go to Martin next.
Yeah, thanks for the question, and I think sort of insightfully you probably revealed some of the answer, which is that part of our task here has been to, and part of what we're enthused by, is to try and put those things into place that are sort of strategic, medium-term prevention, reducing health inequalities. But part of the problem we have, that we've probably spent 90% of the day here talking about that, is to avoid, in our own time, spending 90% of the time talking about, what are the ambulance wait times, what are the sort of, waiting times for elective care, and all the other bits that actually there are massive pressure both on the board and on the organisations to deliver national targets. So I think part of the trick, or part of the, I suppose, role of the non-exec is to try and keep pushing that focus into the future and try and avoid getting down into that day-to-day detail that there's sort of too many people sometimes in the health community here focusing on. We've got to keep some people back to say, no, let's keep that headspace up so we can try and put some of these future things in place or drive towards them and not get dragged into that daily grind of the problems that we have.
And just before I bring in Nick, I was going to say this anyway, so it's a perfect opportunity to do it. Governance isn't the answer, it's just the mechanism for making things happen. But when non-execs and execs get together, historically, there's been what they call committees in common, which is lots of people sitting in a room and you can't decide, you've got to go back to your own house to get decisions. We are the first in the country, in Cornwall, in the Isles of Scilly, to have actually ceded authority as 3 boards, Royal Cornwall, Cornwall Foundation Trust and the ICB, down to a new group, new committee that's actually called the System Improvement Quality Committee. Right? Nick chairs that. And in a second, I'm going to ask Chris and Susan to make some clinical observations. But if you think about not only getting Nick's non-exec perspective, but actually the fact that as a group of non-execs and execs, we're bringing a different governance structure of working as one and empowering one, that is a new dynamic that shows the collaboration we've got. So Nick, please give us your view.
Yeah, thank you, John, and thank you for the question. And like I say, I'm the newbie on the board, and it was like, why are you going to do that? And actually, it's because I can see genuine change. So I think you asked a couple of questions. One is around how we hold people to account, and I definitely feel that this organisation allows me to challenge respectfully and do that in the right way. And I think that's important to say out loud. The other thing, as John's just said and stolen my thunder, is, OK, Nick, so now you're going to chair the System Quality Improvement Group. And to which Emma reflected on earlier, is actually a group which is going to make the things that we've talked about in this room happen, and happen well in the right respective way, a respectful way to both the people that deliver that care, because it's people that deliver that care and the people that receive that care. So, I am a pharmacist by background. I'm not, clinically is all right, but definitely clinically isn't. It's about system approach, it's about people approach, it's about that kind of thing. Susan and Chris actually, hold that to account. To have the 3 chief medical officers, the nursing officers, the 3 chief executives, all their deputies, all within that space, being led by quality as well as finance, but being led by quality to deliver care, as we've heard today, where people need it. The first ICB in the country that's set that up to be able to do that, I think shows you not only intent, but absolutely direction of travel. Thanks.
I should also say that Nick is also the chair of the National Pharmacy Association.
I am, yeah, for declaration of interest, yeah, and that's good fun.
I'm going to bring Stephen in a second, but before I do, it's a nice segue from what that group is talking about. Chris, maybe you could talk about diabetes. You presented it this morning. That's what the team have been focusing on there. But give us a wider clinical dynamic.
So great question. So I think, when you talk about the operational pressures and how do we deal with that? Well, we know the answer. We deal with that by having that prevention, that channel shift approach. But it is challenging to get the balance right. But what I would say is, when you ask our colleagues in the workforce, even if you ask our colleagues in the emergency department, they understand that the solution is not to build a bigger emergency department. It's actually to have that prevention. So Kate mentioned we've been through an ICB restructure. We do have now programs of care, one of which is urgent emergency care and intermediate care. And the CRGs, the clinical reference groups that now feed those programs of care, have been given a very clear mandate that they're there to think about prevention, personalisation as place, and not just think about that problem as an insular problem. So I think the next year is putting this new restructured, this new group to the test, so that we actually start seeing that prevention and the change into the community. And there's already, there's lots of pieces of work that's already happening. You've heard about the same-day emergency centres in Bodmin, West Cornwall, Penzance, and soon to be Camborne. So there are actual changes of care to try and have that more community-facing approach.
When you're sharing your thoughts also, can you just possibly touch on the clinical reference groups as well, so everyone understands how they fit in, please?
So we were very clear when we started the ICB that we're clinically led, and I know we spend a lot of time talking about money because we have to show that what we're doing with taxpayers' money is giving us the best return on our investment. However, in order to do that, we have got to have a call to arms of our clinicians. And the best way to do that was to form what we call the clinical reference groups. Now, that term clinical, people may feel that what that does is isolate folks who aren't clinicians. And we know that we have a huge amount of people in the voluntary sector that we would not want to alienate from those groups. We need them on the groups. But in terms of a parlance, that's where we've gone with the titles, the CRGs. So each of our clinical reference groups will represent areas of care, areas of specialties, and we've talked about a few of them already. We already have the women's hubs up and running, so we have a women's group. We would like to do the same for children, young people, maternity, neonatal. So this is something I think is going to evolve. We started with those areas that we knew were really pressurised, some of those specialties particularly that were driving our numbers of folk that were either coming to harm because of long-term conditions or actually dying prematurely. So those were some of our sort of forerunners for the clinical reference groups. And I just wanted to reflect, if you just give me a moment, that when I was the Chief Operating Officer at RCHT during COVID, one of the great successes in Cornwall, and something I think we should be all proud of, was we never stopped any of our cancer services. An awful lot of our colleagues across the country did, and we didn't. And one of the reasons why that happened was because the clinicians drove it. Nothing moves in healthcare unless the clinicians are driving it. You'll bore people if you talk about money, whilst it's necessary. If you can talk about what makes a difference, and we are in the business of people's health and well-being, if you can talk about what makes a difference and how we improve things, you get clinicians on board, you get clinicians to listen. However, the money is important because it buys us new technologies, it buys us better ways of doing things. So if we can put our clinicians and our wider group of individuals that support our clinicians as well at the forefront of everything we do, I think we can start to realise all of the plans that we've talked about today and will continue to talk about. Thank you.
Thank you very much. So I'm going to bring Steve in, but Patrick, I'm going to ask you to wrap up in a second, and Kelvin, I'll ask for some words. And any other colleagues on the screen who would like to make observations, please put your hand in the air. I'll bring you in, because the one thing I do is try and actually bring everyone the voice to the table. So, Steve.
Thank you, John. Great question, Rebecca. I'm not an executive director of the board, nor am I a non-executive director. I'm similar in some respects to Nick in a partner member role, so I appreciate the question was directed to non-executive directors. I also think one of the things that we've seen in our board is as we've developed our relationships, are holding to account of each other. So in parallel to the holding to account that non-executive directors exercise, I think we're seeing a much stronger holding each other to account as different organisations on the change transformation plan that Kate outlined. I think that is really helpful. For me, the most urgent thing for us to improve is ambulance handover and response times. And I know my SWAST ambulance service colleagues would say that, but I think all of our ICB board members would share that view, that while some progress has been made, that must accelerate so that we can do the right thing for our patients. And there's a tension there, and I think you're alluding to it before. How do we create the capacity for the longer term transformation, which is critical to our ability to deliver for the future, but also make those changes at speed. And I think Susan's comments about the call to arms to our clinical reference groups is a key way in which we can achieve that. And if we can move quickly enough, that will give us, I think, the capacity to make those immediate improvements whilst delivering the transformation for future years.
Thank you. So I'm going to look at the screen and see if anybody else on the screen would like to, before I get to Kelvin. Hester, is there anything, actually, I know you're not on the board as such, Rachel would normally be here. Is there anything, Hester, that you would like to add or question this one?
No, thank you very much, John. Just great to be here today and hear some of the examples of what you're doing and all the work that you've got planned on the year ahead, and looking forward to supporting you through it.
Thank you so much. So, Kelvin, tell us a little bit about technology and digital and the way forward, please.
Yes, thanks, John. So actually, the last question was a really interesting one, because the whole world of technology is both about change for the future, and I'll talk a little bit about that in a moment, but actually supporting all of our services on a day-to-day basis. And I noticed when we saw the video at the beginning, the shots were very often interspersed between people working together, seeing patients, but lots of pictures of people in front of computers. But actually, a big part of what we want to do is actually reduce the amount of time that people have to spend in front of computers. We really have a goal of allowing more time to be freed up to actually have face-to-face contact with patients. So our technology drivers are around simplifying the way that services are delivered, but actually the old analogy of you're trying to change the aeroplane whilst it's flying is never truer than in our world of technology, because the whole of our services are dependent on that technology, and we can't afford to actually take that down when we're making changes. So we're literally making changes at the same time as actually delivering the services. So working through those, we are always working on the basis of making sure that what we're delivering now is as efficient as possible, meets the needs of everybody. But looking to the future, it's very much about, in line with the whole aim of bringing the delivery of care closer to place, is actually putting control in the hands of people who use our services. So we really do want to make sure that people can access services through digital channels, they can access support, so that when they need to actually then see a clinician, they really know that that's needed, that they've had access to anything that they can possibly access ahead of that to help smooth their way through the overall process. And exactly as Patrick was saying, some of the challenges around workforce, that's one of the positive aspects of where in other sectors we're seeing that technology is seen as a bit of a threat for the workforce. Our workforce challenges are such that we're going to need technology to help us deliver the services more effectively, and to be able to cope with those reductions in the available workforce as the shape and size of it changes over time. So certainly from our point of view, the more we can engage with people around the design of those future services, and I know Lucy's doing great work in terms of engaging with people, and we really want technology to be part of that. We work with people to actually understand the things that they want from services. And the thing I really mustn't forget in talking about technology is absolutely recognising, for people who find it hard, putting in place support services alongside the technologies, and which we actually work with council colleagues who have a really excellent digital inclusion service. So we're supporting and working together with council colleagues on that, because actually our colleagues there have the same needs of making their services accessible to everybody as well. So that's a very quick overview of the things that we do. Don't know if that prompts any questions from anybody.
Yeah, that's really excellent. Thank you so much. We're going to try and, for those who know me well, we start on time, we end on time, except today we started late, so I'll try and end on time. I can see before Kelvin went on full screen, Debbie, you'd like to make an observation, please.
Yes, thank you, Chair. I'm afraid the sound's been slightly glitchy, but I wanted to follow up on Susan's summary of the importance of being clinically led as a system, and also some of the clinical reference groups, to give a shameless plug for the new mental health, learning disabilities and autism programme of care group, under which sits the clinical reference groups. And this is chaired by Dr. Adrian Flynn, who is our Chief Medical Officer at CFT. And I'm rather hoping that colleagues will agree that this new group, which is a system group with partners from all agencies, has got off to a good start. And the big thing that's really going to be different this year, colleagues, is that to get working together, those colleagues in that group will be able to make recommendations about priorities for our plans for the coming year and for future years. And that's really quite different to how we have worked previously, where we have each made plans and priorities. And I'm really very encouraged by the early progress that group makes. So I'm very optimistic for further developments together as a system with mental health over the coming year.
Thank you so much. So I'll put the last word, if I may, to our Chief People Officer, because to be blunt, we don't go anywhere without our staff. So, Patrick.
Thanks, John. Last word. Let's see if I can do justice to that. So the question which initiated this part of the debate, I think, names the biggest challenge we've got, which is capacity capacity to change. And some of the conversations I've had today, reflecting on people's experience of working in this system or other systems over the years, is absolutely no shortage of ideas for improvement, and probably a lot of consensus about what that would be. But the ability to implement those is, is a consistent learning. As referred to earlier, I think in an ideal world, I think Neil might mention this, we double run. You'd say this part, just carry on delivering everything that we need to do now, and these resources create the new world, and we'll merge them. But it's not going to be as simple as that, because we haven't got the resources. So the creativity we're going to need to do to implement gradually, incrementally, but in the common direction that I think we've all heard about today. I think that will be our way forward. And certainly, as referred to, the ICB through its redesign has sought to create capacity for that innovation and improvement in the CRGs, the programs of care teams. And one area that hasn't got mentioned is our Transformation Support Hub, which is a part of the organisation that will be supporting and facilitating system-wide change. So not an easy challenge to rise to, but some of the building blocks in place.
Thank you. So I can turn to Molly, our Company Secretary. Molly, have we done everything we need to for our formal annual general meeting from your seat, please? I'm going to take that as a yes. I'll take that as a yes.
Yes.
Yeah, thank you so much, Molly. Okay, so it's past. So on that basis, can I just thank, well, first of all, can I thank the board? Thank you to you personally. Thank you to your teams. Thank you to the partners and colleagues in the system. Thank you to you for arriving here and staying all day today. Hope you've enjoyed it as much as I have, because I have actually enjoyed it. And I look forward to what comes next. So have a very good and safe journey home. Take care. Thank you very much, everyone. So, do I put mine in on the top and then pick it up? Is that okay? Are you ready, everyone? I know the only reason why you stayed, isn't it? Really, I'm going to give it away. You're going to pick one out. What am I doing? Picking one. Two. Okay. So just to keep it exciting, are you ready? Just to keep it exciting, unless for those who have got green and yellow, stay excited. For those blue, I'm sorry. Okay. So here we're going to go. As I've got green, we'll do the yellow one first. Are you ready? Yellow. 1, 2, 1. Okay, and the second one is green. Not quite, I was just a bit out. Okay, green, 1, 6, 8. And just before you all go, can I ask you to put your hands together and thank Lucy and Jenny and Pete and the whole team. Thank you so much. Safe journey, everyone.